Dear fellows, Assalamu alaikum and very good morning. Welcome you all to today's Friday Eco 2020 Eco Dhaka EU workshop. It's a very pleasure that we are on the day 17 of this workshop series of webinars. And as usual, this program will be chaired by Professor Abdullah Shafi Majumder. He is the President, Bangladesh chapter of ISCU. Am I audible?
Yes, sir.
রাজীব স্ক্রিন সরে গেল কেন? স্ক্রিনটা সরে গেল। Today we have two renowned speakers, Dr. Mohammad Kabiruzzaman and Dr. Abdullah Shahriar. Dr. Mohammad Kabiruzzaman is itself a reference person for the echocardiography in Bangladesh, and he is the Associate Professor and Senior Consultant of National Heart Foundation Hospital and Research Institute, Dhaka. He will talk to you on echocardiographic evaluation of infective endocarditis. So this is a very important clinical topic. And the second presentation will be delivered by Dr. Abdullah Shahriar. He is the Associate Professor and Head of the Department of Pediatric Cardiology of National NICVD. He will talk to you on echocardiographic evaluation of Tetralogy of Fallot. So this is also a very common topic encountered in day-to-day practice. We have two eminent panel of experts. Professor Mir Jamaluddin, he is the Director and Professor of NICVD, the premier institute for cardiovascular care in Bangladesh. And also we have got in our midst Professor Nazir Ahammed Chowdhury. He is the ex-professor of cardiology of NICVD Dhaka. He has other aspects. He is one of the few Bir Muktijodhas among the cardiologists, and also he is a poet as well. So we have actually a very rich accumulation today. We hope we all will enjoy today's webinar. At first, I like to invite our chairperson, Professor Abdullah Shafi Majumder, to welcome all and start the session. Sir, please.
Thank you, Dr. Manohar, for initiating the program. Good morning to everyone. আজকে খুবই আমরা happy যে we have got two what will I say, the very nice speakers. Dr. Mohammad Kabiruzzaman who will deal with the he will talk on the infective endocarditis. Is a very clumsy topic for the echocardiographers in diagnosing and giving the prognostic views of the infective endocarditis. And also we have got the Dr. Abdullah Shahriar, head of the Department of Pediatric Cardiology in the NICVD. So he will be talking about the Tetralogy of Fallot, and we all know the Tetralogy of Fallot is the grammar of congenital cyanotic heart disease. আমরা যদি টেট্রালজি অফ ফ্যালোটটাকে ভালো বুঝতে পারি তাহলে অন্যান্য congenital cyanotic heart disease কে আমরা ভালো বুঝতে পারবো। এটা আমার পারসেপশন আর কি ফ্রম মাই স্টুডেন্ট লাইফ, যে এটা একটা কাজে টেট্রালজি অফ ফ্যালোটের ধারণাগুলি ভালোভাবে নিতে পারলে আমাদের অন্যান্যগুলি সম্বন্ধে ভালো ধারণা হয়। আর আমি ভেরি হ্যাপি যে আমাদের যে প্যানেল অফ এক্সপার্টস, the director of the NICVD, Professor Mir Jamal, agreed. He is so busy person as the director, but he agreed to be the panelist of today's session. And also Professor Nazir Ahmed Chowdhury, as you have already mentioned, that he is a great freedom fighter as well as he has some involvement in the literary pieces of work, and he will be another panelist. So with this, and also along with us, I saw a number of the important faculty also. I found Professor Abdullah Chowdhury, Dr. Shaila Nasrin is also there, Dr. Jillu Rahman is with us, Dr. Alam is also with us, Dr. Kabiruzzaman is with us, Professor Tawfiq Professor Abdul Salam is always with us, and Dr. Swadesh from Khulna, Shahriar Kabir from Dinaspur. So and Naharuma Chowdhury is always with us. Rajiv from Chittagong or Chittagong Hill Tracts, as both he represent both. Anisul Awal from the Chittagong Medical College. So Lejo and Arima. So it is very good presence of the great faculty, and I hope that we will enjoy these sessions. So before that, I have an announcement in that the next Friday, that is on the 9th of October, there will be a session by the Bangladesh Society of Cardiovascular Intervention, to which many of us are also the active members of the society, and they will organize the day-long program from the 9 a.m. So we announced that we will postpone our Friday echo on that day, on the 9th October. Our next program will be on the 16th October, and we will come with the many interesting topics such as transesophageal echocardiography, the stress echo, the strain echo with the strain, and so many other topics. And we plan to have another session of the CMR, and also the CT angiogram and comparison with the echocardiography. So in the next few weeks, we have a very interesting topics to be discussed. And again, I request my fellows to be active in these sessions, to ask the questions, and to remain regularly in this session so that we can recognize your presence at the end of our program, that you participated in this continuing medical education program. With these words, I hand over the charge to Dr. Manohar to continue the session.
Thank you, sir. Thank you. The first presentation, as I have already mentioned, that will be on echocardiographic evaluation of infective endocarditis. And this presentation will be by Dr. Mohammad Kabiruzzaman. Dr. Mohammad Kabiruzzaman, sir, is one of the few luckiest persons of the country who have got formal training in echocardiography abroad. And he also owns echocardiography. I think he may also dream echocardiography in his sleep. So let us enjoy the deliberation by him. Sir, please.
Thank you, Manohar. Kind words and appreciating words. I don't know who I am. So I'm not sharing this screen. Okay, so my topic is the echocardiographic evaluation of infective endocarditis. It's a very crucial point, and you know, the infective endocarditis is a grave disease. If the identification of the disease is late, mortality is very high. So the combination with clinical and bacteriological data and the echocardiographic findings of valvular visitation allows for an accurate diagnosis of endocarditis. So infective endocarditis usually diagnosed on the basis of Duke's criteria. It is similar to the Jones criteria, and it have different component part like pathological criteria, clinical criteria, major criteria, minor criteria. For echocardiographic part, we are concerned about the major criteria. So these are some pathological criteria. I will not go details to this. These are minor criteria. These are the major criteria. Among the major criteria, one is the positive blood culture for infective endocarditis. Another is the evidence of endocardial involvement. Evidence of endocardial involvement can be determined by three techniques acceptable. One is the positive echocardiograph for infective endocarditis that we are concerned today. Other is PET-CT or SPECT-CT and definite paravalvular lesion by cardiac CT. So these are the Jones criteria. You were to the clinical criteria that there is permutation and combination of different criteria. For diagnosis of the infective endocarditis. Now, the role of echocardiography for diagnosis of the infective endocarditis. Actually, the echocardiographer, but those who is doing the echo for diagnosis of the infective endocarditis, he should be tuned about the clinical diagnosis so that he can concentrate and search for the culprit visitations, because these are tiny structure. Unless and until you are very much tuned in your mind that I have to search out some sort of very tiny oscillating mass, then otherwise it may miss or you can omit it, or there may be failure of the detection of the visitation. So this is again the Duke's criteria. This is the major criteria. I have highlighted here the positive echocardiogram for infective endocarditis. These are the some few points. These should be evaluated by echocardiography for diagnosis of the infective endocarditis. One is the visitation, another the abscess, pseudaneurysm, intracardiac fistula, valvular perforation, aneurysm, and new partial dehiscence of the prosthetic valve. Now, the role of echocardiography. Actually, comprehensive echocardiographic imaging for suspected infective endocarditis should be guided by index of clinical suspicion. It's very important, index of clinical suspicion. And while maintaining an objective differential diagnosis of findings that could represent or mimic endocarditis, there are many differential diagnoses of visitation that should be kept in the mind. Now, regarding the transesophageal echo and the transthoracic echo. Transthoracic echo is adequate in some cases, but transesophageal echo imaging is more sensitive and specific, both for the detection of the valvular visitations and for detection of complications. The initial machines, they have expressed their sensitivity and specificity for transthoracic echo was 60 to 70%, but nowadays the improved quality echo machine have the sensitivity ranging from 70 to 90%. For by transthoracic, 70 to 90%, it's a wide variation. It does indicate the more you are meticulous, more you are attentive in searching the visitation, then more will be the accurate findings of the visitation. Now, goal of echocardiography, what are they? We have to identify the visitation, the presence, location, size, and number of visitations, then dysfunction of the affected valve, especially valvular regurgitation, underlying anatomy of the affected valve, or any coincident valvular disease, impact of valvular dysfunction on a left ventricular size and dysfunction, and other complications of endocarditis, that is paravalvular abscess, pericardial effusion like this. So by 2D echocardiography, multiple acoustic windows are needed for detection of the valvular visitation. And because the visitation is a focal structure, it is seen only in certain tomographic bands. And image quality is enhanced by use of higher frequency transducer and magnification of the area of interest. And note, small normal variants of valve anatomy should not be interpreted as abnormalities. Now, for 2D echo, the image quality is optimized by use of minimum depth of the sitting. This is very important. Whenever one is to search for visitation, you have to decrease the depth, adjust the gain, and you have to also decrease the width of the image. That will increase the resolution of the image. So make careful assessment of the valvular anatomy, evaluate the size and dimensions of all 4 chambers, and evaluate LV and RV, both systolic and diastolic function. A small pericardial effusion is seen in patients with infective endocarditis, but large pericardial effusion raises the concern of purulent pericarditis due to direct extension from a paravalvular abscess. So, regarding the Doppler echocardiography, both the qualitative and quantitative evaluation of the valvular regurgitation is done with Doppler echo as like native valves. And you must evaluate the pulmonary pressure of the patient. Regarding the 3D echo, often improves the visualization of the visitations on transthoracic echo in some patients, depending on the image quality. But disadvantage of lower spatial resolution and slower frame rate. You know, the visitations are very highly mobile, visitating, oscillating structure. So the frame rate should be high to have a clear image of the visitation. That is contradictory to the 3D echo. Now I will highlight some points of the visitation. So visitations are a hallmark finding for infective endocarditis. And these are oscillating in the intracardiac mass without an alternative anatomic explanation. The movement, behavior, and clinical scenario in such that if one should see the structure, then it's like that without an alternative anatomic diagnosis or explanation. So, what are the other characteristics of the valvular visitations? These are an abnormal echogenic irregular mass, usually attached to a valve, site of attachment on the upstream side of the valve leaflet, and visitation attached to leaflet have independent chaotic movement. That is important. I will show the in a movie. This is a schematic diagram. This is the aortic valve. In case of regurgitation, usually the visitations are attached at the upstream side of the regurgitant lesion, actually at the site of differential pressure difference between the regurgitant lesion. So this is the initial part of the regurgitant lesion, that is the most differential pressure with differential characteristics that initiate the visitation formation. For aortic regurgitation, it is the LV side of the aortic valve that is the common site for the visitations, and you see these are the multi-lobe irregular structure. And during diastole, it comes into the alveoli, and during systole, it enters into the aorta. For mitral regurgitation, the visitation is usually attached to the LA side of the mitral valve. So during systole, it comes to the left atrium. So this is in the cine loop video clip to see the characteristics of visitation. You can see this is the prosthetic tissue valve, and this is the multi-lobe irregular oscillating chaotic movement of the classical example of the visitations. And here one characteristic is important. For the prosthetic valve, if you consider the metallic valve, the visitation attached to the leaflet is very rare. It's not usually found. In the prosthetic valve, visitation usually attached to the swing ring. But for tissue valve, you may have the visitation attached to the leaflet. There is an important message from this image. And this is the M-mode stressing to see the oscillating movement of the visitation. This is the modified apical four-chamber view, and the M-mode cursor is placed on the visitation, and this is the irregular oscillating movement of the visitation. This is another M-mode crossing. This is the parasternal larynx's view. The M-mode cursor is placed on the visitation, and this is the irregular chaotic oscillating movement of the visitation. So if you consider the prevalence of involvement of the valves, the mitral valve is most commonly affected, then aortic valve, then tricuspid valve, and least is the pulmonary valve. The involvement is like the involvement of the rheumatic fever. So this is the still picture, transesophageal echo. You can see the vegetation attached at two sides. One is this is the NCC, and this is the posterior of the LA, aorta. The size of the vegetation. The fungal visitations tends to be larger than those caused by the bacterial infections, and visitations involving the tricuspid valve tend to be larger compared with visitations of aortic valve and the mitral valve. And this is the still picture, modified apical larynx's view, showing the large fungal visitations. Now, the size of visitation and the resolution power of the echocardiography. So TEE, transesophageal echo, provided excellent imaging. Higher frequency imaging greatly improves spatial resolution, and visitations of 2 to 3 millimeter in dimension can be detected by transesophageal echo. And these are the some echo criteria for definition of the visitation. These are some repetition of the concept. So positive features are low reflectance, attached to valve upstream side, irregular shape, amorphous, mobile, oscillating, associated tissue changes, valvular regurgitation. Negative features are high echogenicity, non-bacterial, non-valvular location, smooth surface or fibrillar, non-mobile, absence of regurgitation. So there is maybe some confusion in visitation and thrombus, but distinguishing visitations from thrombus is virtually impossible on echocardiographic ground alone. Invariably require clinical correlation. That is important. And now I will mention some differentiating point of active versus healed visitation. The sequential echo study in patients undergoing the effective treatment of the endocarditis typically show the gradual reduction in size, decrease in mobility, increase in echogenicity of the visitation. These 2 points are important, decrease in mobility and increase in echogenicity of visitation. So this is a still picture showing the increased echogenicity of the visitation that is attached to the posterior wall of the aorta. This is the transthoracic image, and you can see the size 10 into 70, very large visitation. When visitation size more than 10 millimeter, it requires surgery. So this is the video loop showing the active visitation. You can see this is the visitation. This is the oscillating chaotic movement, have the independent motion other than the movement of the cusp of the aortic valve. And we can see the echo texture is almost similar to the myocardium of the active visitation. This is important. And this is an example of the healing visitation. This is from our institute. He was getting antibiotic treatment for infective endocarditis. You can see this visitation mass is more echogenic than this, and it's a less mobile, less chaotic movement than this. So these are the differentiating point for the healing visitation. So this is another example of the still picture for a visitation attached to the aortic valve. This is the still picture of the visitation attached to the mitral valve. And this is the aortic and mitral valve visitation in both in same patients. You can see these are active visitation. These are the characteristic, fantastic, and movement. Actually, these type of images will make you the confident that this is an visitation. So this is a still picture, the visitation attached to the tricuspid valve associated with tricuspid regurgitation. So prosthetic valve visitation, as I have already mentioned earlier, visitation on prosthetic valves most often occur on the base of the swinging of the structure. This is applicable for metallic valve, not for tissue valve. And you can see the still picture of the transesophageal echo. The visitation is attached to the swing ring on the LA side. And now the pacer lead infections. Pacer lead visitations resemble valvular visitations. A mobile mass attached to the pacer lead with independent motion. But small fibrinous strands are common on pacer leads, and small thrombi also may be seen. And you can see this is a still picture. This is the picture of thrombus. This is the pacer lead. These are the visitations. And you can see in video loop, that is the characteristic moment of the visitation. Now some points regarding the non-bacterial thrombotic endocarditis, typically seen in patients with malignant disease and systemic lupus erythematosus. And these are somewhat similar to the infective endocarditis, but these are a bit different because these visitations tends to be smaller, are located near the leaflet base, show variable echo density. These are more echo dense the untreated visitation and have less independent motion. And these are the still picture for example of the non-bacterial thrombotic endocarditis. That is attached to this is the patient from a metastatic cancer, masses on the tip of the mitral valve is noted. This is the nodular, almost nodular structure attached to the AML of the mitral valve in case of systemic lupus erythematosus. So some of the echo findings may be mistaken for visitation. These are the differential diagnoses for the infective endocarditis. One is the papillary fibrillostoma, myxomatous mitral valve disease, non-bacterial thrombotic endocarditis, thrombus, beam width artifact, normal valve variants such as limbal excretions. I will show some example. You can see this is the mitral valve prolapse with a flail PML. This may be confused to the visitation. You can see this is a flail PML. It looks like a visitation, but this is not infective endocarditis. And we can see the flail PML, the same patients of different images, different angle, different windows. This is the flail image because the PML is directing away from the LV apex. That is, but the movement is characteristically, it is oscillating, but echogenicity is higher than the untreated visitation. This is the apical fourth chamber view again, the flail PML, same picture, same patients, showing the mitral PML, flail PML, confused with the visitation. So this is the normal characteristics of the limbal excretions of the aortic valve. These are filamentous, and these are more echogenic than the visitations. And this is one example of the blood cyst that is attached to the anterior mitral leaflet. This is a broad brace, and the surface is regular rather than irregular, and it is the multi-lobed that is found in the visitation. So I will talk now a few words regarding the complication of endocarditis. The complications may be structural and hemodynamic. What are the structural complications? These are the leaflet rupture, flail leaflet, leaflet perforation, abscess, aneurysm, fistula, prosthetic valve dehiscence, embolization, pericardial effusion. And these may lead to hemodynamic consequence of acute valvular regurgitation, valve obstruction, heart failure, intracardiac shunt, tamponade, perivalvular regurgitation. Now I will talk about the perivalvular extension of infection. And this is the extension of infection towards the perivalvular tissue. And fate of perivalvular extension of infection are like this. It may turn to the paravalvular abscess. It may turn to the mycotic aneurysm. It may turn to the aneurysm of the sinus of Valsalva. It may do or effect or cause the dehiscence of the prosthetic valve ring and may induce the fistula, causing intracardiac shunt. Now, I will highlight some points regarding the perivalvular extension of infection in the form of paravalvular abscess. How does look it like? One should be keep in mind mind should be known that what is paravalvular abscess in case of infective endocarditis. So the high index of suspicion is needed by the echocardiographer, and subtle abnormalities suggesting valve abscess should be carefully evaluated. And an abscess is the localized pocket of infection, as you all know, and most often caused by staphylococci and enterococci for infective endocarditis. And these cardiac must have some variable echocardiographic images. They may be echolucent, or they may be echodense, or they may be mix up of echolucent and echodense. And that distort the normal anatomic boundaries of the periannular region. And typically abscess occur in the valve annulus adjacent to the infected leaflet, and most common with aortic, then with the mitral valve endocarditis. And mostly with aortic valve endocarditis, perivalvular extension of infection often targets the mitral aortic intervalvular fibrosa. This part is important because this, I will show the anatomy of the mitral aortic intervalvular fibrosa. And this is the mitral valvular intervalvular fibrosa. Sorry. This is the part. Actually, this is the fibrous continuity of the between the aortic and mitral valve. This is the intervalvular fossa or region between the non-coronary cusp of the aortic valve and anterior mitral leaflet. This is the triangular shape. The base is formed by the transverse sinus, the least vascular structure. and normal thickness is 3 millimeter or less. This thickness will guide you whether this region is thickened or not. That will make you suspicious whether there is spread of infection in the perivalvular or in the annular area is present or not. So in standard suprasternal long-axis view, this is the mitral aortic intervalvular fibrosa area. And you can see the still image of the transthoracic echo showing the increased echogenicity and the echolucent and echodense and thickness of the posterior aortic wall. And this is the increased thickening of the annular area, annulus of the aortic valve. And this is, you can see the abscess cavity that is involving the mitral aortic intervalvular fibrosa. This is the anterior mitral leaflet. This is the non-coronary cusp of the aortic valve, and this is the abscess. This is the echolucent area. And you can see these are two transesophageal echo. Transesophageal echo can show you the better image of the, and additionally you can see that there is vegetation attached to the aortic valve. This short axis we show the bicuspid aortic valve. This is another still picture from our laboratory. You can see the short axis view at the great vessel level. It is the bicuspid aortic valve. You can see the thickness of the posterior wall thickness. It is 8 millimeter. So thickness more than 3 millimeter is should guide you that there is extension of infection. And you can see there is some area echoluscent, some area echodense. Now the paravalvular abscess. The abscess may rupture to allow communication with one of the cardiac valve, chetic false aneurysm or myocardic aneurysm. The same name for the same structure. Some of the authors have used the myocardic false aneurysm. Some authors use just a myocardic aneurysm. And these are defined as an echoluscent outpouching of the vessel wall, or in case of aortic root, the coronary sinuses. And after the pericardial abscess, myocardic aneurysms are the next most commonly observed with perivalvular extension of infection. And again, the mitral aortic intervalvular fibrosa is the location where false aneurysms most frequently occur. And you can see the still picture. This is the transesophageal echo image. This is the LA side. This is the anterior mitral leaflet. This is the posterior wall. This is the myocardic aneurysm. And this is the area of the mitral aortic intervalvular fibrosa. And these have the wide communication of the alveoli. And this still picture, this is the systole, the color going inside the aneurysm, and the diastole, and this is the systole. The color is coming out from the aneurysm. And you can see this is the video clip. You can see this is the myocardic aneurysm. And you can see this is the communicating channel with the alveoli. And you can see this is the color flow. The color is going through the channel inside the aneurysm. Now this is the vegetation that is attached to movie. That is the right coronary cusp of the aortic valve. This is the transthoracic echo. If you have very good image of the transthoracic echo, then you can confidently comment about the vegetation. And you can see this is another vegetation that is attached to the posterior wall of the aortic valve, but it is encroaching on the aortic valve during diastole and causing severe air. In color flow of this patient, there was severe air. And you can see this is the LV is dilated for your eyeball estimation. Now, complication of the myocardic aneurysm. It may expand along the circumference of the aortic annulus and root. So it may cause local compression on the left coronary artery, and it may have the fistulous rupture in the aortic root or left atrium and lead to intracardiac shunt. So this is a still picture showing the myocardic aneurysm, that rupture into the RV. This is the transthoracic echo, still image. Now the aneurysm of the sinus of Valsalva. It occurs when the aortic wall is infected and diagnosed based on the dilated and distorted aortic sinus, even in the absence of rupture. So now the rupture of the aortic annular abscess. What are the rupture point of the abscess? So this results in different complications depending on the extent of site of rupture. The fistulae from right coronary sinus in the right heart chambers. It may rupture from left coronary sinus to left atrium left ventricle, or from non-coronary sinus, it may rupture to all 4 cardiac chambers. So this is then the rupture of the mycotic or abscess into the leading to the ruptured coronary sinus of Valsalva. There is the shunt developed between the aortic root and the right atrium. Now, I will talk few words regarding the paravalvular abscess of the mitral and tricuspid valve. It is less common than the aortic valve, and the abscess formation is less frequent. But for mitral annular abscess, mycotic aneurysm formation is quite uncommon. Perivalvular dehiscence would be the most common complication. But this perivalvular dehiscence is mostly found in case of prostatic valve insertion. So it appears as an increased thickening and echogenicity in the posterior aspect of the mitral annulus. One important thing you can notice that the annular thickness, both for aortic valve and mitral valve, usually found in the posterior part of the both. So an infection can extend into the basal segment of the ventricular myocardium or into the pericardial space. And this is the example, an abscess within the mitral anterior mitral valve leaflet. And we can see the visitations with the dehiscence of the prostatic valve. You can see this is the metallic valve. Very nice opening and closing of the bileaflet metallic valve in mitral prosthesis. And you can see this is the dancing, chaotic and oscillating movement of the visitation. And it is attached at the swing ring. And there is dehiscence this at the annulus. And this is the rocking movement of the prostatic valve. Okay. That's a very good example, nice picture. Now, I'll talk about the embolization of the visitation. The sudden disappearance of visitation. What does it mean? Sometimes visitations abruptly disappear from the heart because of embolization. Thus, a patient with active endocarditis may have no visible visitation if recent embolization has occurred. So this is important. Now, this is the multiple visitation in the setup of ventricular septal defect. You can see this is the ventricular septal defect, and there are multiple visitation. One is attached to the septal leaflet of the tricuspid valve. Another is with the VSD margin. Another with others are at the free wall of the RV infundibulum. And this is the visitation in the valve conduit from RVOT to mitral valve main pulmonary. This is the conduit, and this is the visitation in valve conduit. Now I am at the end of my lecture. What is the conclusion? You have to draw it. So visitations are abnormal irregular mass with oscillating movement, and perivalvular extension of the infective endocarditis should be carefully evaluated. And paravalvular abscess commonly affect the mitral aortic intervalvular tragusa. Dehiscence commonly occur in prostatic mitral valve. So now the wisdom and knowledge. Knowledge implies the timely and rightful application of knowledge, and knowledge may even be for or an encumbrance unless you learn to use it justly. And thanks for patience hearing. Thank you.
Thank you, sir, for your brilliant presentation. I think this is very lucid and at the same time full of examples. So this may be a very comprehensive one on the part of the audience. Thank you, sir. Thank you. Now is the time for question answer session. Before that, May I ask Professor Mir Jamaluddin? Sir is one of the two expert panelists of today's CME workshop. May I have some comments from you, sir? Mir Jamaluddin, sir.
I think he is disconnected.
Maybe.
Professor Abdul Wadud is here.
Abdul Wadud Chowdhury, sir. Sir, can you hear me?
Assalamu alaikum and good morning to everybody. I think Kabiruzzaman Bhai, as always, has shown with very good examples how and where to look for the vegetation or other manifestations of infective endocarditis. And you know, we are sometimes really in trouble when we cannot find a credible source of the pyrexia of unknown origin. So in those cases, echocardiography is often come to our surface by showing that actually is the infective endocarditis subacute form that is the reason of this pyrexia of unknown origin. And to have a good idea about how to actually find out whether the valves are actually involved, where the suspected vegetation are hidden, that can help us. And I also, I would have given him a little bit more, I wanted him to give more emphasis on the clinical features he would be asking the patients when he is going to look for visitations in a patient.
Yes, very good.
Clinical feature, you will be asking the patients. You are not finding any vegetation, but still you are suspecting that could be infective endocarditis. What are the clinical features you will be looking for?
Are you asking me?
Yes, sir.
Okay. Actually, I want to want some clinical experience or echocardiography. Most of the time, we did not have any data regarding the patients when we do the echo. So I got some structure like this patient. Then I spontaneously look at his face. You know, the patients of infective endocarditis have some typical face, very ill looking. And then I ask him, are you suffering from fever? Do you have low grade fever? Do you have a reduction in weight? Do you have any night sweating? I ask this type of questions. If I find some clinical clues, then I comment directly that this is a visitation. And moreover like this, there should be some structural problem in the heart. As for example, recently cardiac surgery with fever, patient is ill looking, not getting from the ventilator, then it's a strong suspicion that there is visitation. But one should ask the patient if he had some sort of fever or not, and other systemic illness, features of systemic illnesses. Thank you.
Thank you, sir.
When you will be asked for visual echo, when you cannot find something in just thoracic echo?
Okay. If you have a bad image, you cannot image the mitral valve or aortic valve properly. You cannot image the posterior wall of aorta properly. There is a blurring. You cannot decide whether it is thickening or not. Then you have to go for transfusion. That is the. But if you have very clean-cut picture of the posterior aortic valve that I have shown in some pictures, the posterior nicely behaved, and you can decide that it is thickened. But one should be keep in his mind what are the probable extensive sites for extension of the infection. He should have knowledge like this. Sometimes there may not be visitation, but the mere thickening of the posterior wall thickness will make you suspicious that there is abscess of a spread of infection in that area.
Thank you, sir. Professor Nazir Ahmed Chowdhury, sir, are you with us? Probably no. Then we can go through some questions in the chat box as well as in the question and answer box. What is the mycotic aneurysm?
As I have shown it in my slides. Okay, it is the cavity in the wall of the aorta or vessels, or in case of the infective endocarditis, it is the mitral aortic intervalvular fibrosa area that I have shown you. Actually, picture can tell you the more than the verbal words. The one end will be widely open, other end will be tapered and blocked. That is the aneurysm that I have shown you.
Thank you, sir. How can we differentiate between aortic aneurysm and paravalvular abscess?
Aortic aneurysm and paravalvular abscess. Paravalvular abscess, it is the name, does it perceive there is the abscess around the valve. Aortic aneurysm, that site will be in different sites. I don't know, it's a very confusing question. The two structure in two different locations. So there should not be any confusion.
Sir, can I add, sir?
You can add.
Another important point is that aortic aneurysm is a diffuse one. It involves the whole of the root of the aorta or other parts of the aorta. And paravalvular abscess usually localized, and it involves a particular segment. If even in relation with the aortic valve and aorta, it should be localized, not involving the whole diameter.
Actually,
of the
you are mentioned that's paravalvular abscess. It does means that the abscess around the attached to the valve, very adjacent to the valve.
As the name signifies.
As the name signifies.
Yes, yes.
Aneurysm is it will be distant from the valve. The aneurysm is by definition the mouth should be wide open, as differentiating from the pseudoaneurysm.
It's very simple.
Any confusion like the paravalvular abscess or aortic abscess.
Thank you, sir. Ajoyda, can you comment on this?
Actually, there is a term pseudoaneurysm, which has only one entry point, making the area mobile during real-time echocardiography. And when there is another end, called fistula, which can be appreciated by color Doppler echo. And an abscess is totally concealed area, the fluid collection, which can be easily detected by the, sir also already mentioned the translucency, and it is the around the aortic valve, most commonly intervalvular fibrosa. I think.
One important thing regarding the abscess, paravalvular abscess, in case of infective endocarditis, when it is around the aortic annulus, there may not be equilucent. It may be mixed, equilucent, equidense, that I have shown. So this is very important to make you suspicious. Even if there is thickening of the aortic wall, that is an aortic abscess. That is an aortic. And pseudoaneurysm is the differentiating point very clear. The aneurysm have wide mouth, pseudoaneurysm have narrow mouth. This is the very basic for differentiating the pseudoaneurysm and aneurysm.
Thank you, sir.
So sometimes we
can,
yes, sir. Sometimes we can take help from CT, which is more sensitive than echocardiography in subtle pathology like thickening or abscess formation. And CT has more sensitive in that case. We can take help from CT.
Right,
no. CT is in many confusing things you can do CT. But you cannot do routine CT. This is not
confusion.
There is some. It may have confusion that bad image. You can make the measurement more accurately by CT.
Yes.
Yes.
Manwar,
Can I have some comment? Yeah.
Yes, sir.
Yes, sir.
Yes, sir.
Or can I make a comment, please?
Yes, yes, sure.
Okay. Sorry. Regarding the use of CT, I think this technology is being widely misused, used and misused. That is the main thing. So I think it should be because of the radiation, because of the contrast, we should not use indiscriminately the cardiac CT. And even it is being used in troponin positive acute coronary syndromes, which is not at all justified by any guidelines.
Right.
So I think this is a dangerous trend in the present cardiology. So I think we should be careful. And regarding the infective endocarditis, other two things is a very dangerous phenomena, because it is the most difficult diagnosis in cardiology. And in our country, I think the majority of the cases we are treating without a microbiological proof, and in many cases the echocardiographic proof. It is the empirical treatment is going on. And another thing is with the reuse of PTMC balloon and the dental procedure. These are the two very dangerous things which are causing increase in the incidence and prevalence of endocarditis in our country. The PTMC balloons are being not sterilized properly. They are being reused again and again to increase the profit margin, but the patients have to pay a very big price, and the physician reputation is also being jeopardized by this practice.
Thank you, sir. Thank you.
Manwar.
Yes, sir. Yes, sir.
আমি একটু অ্যাড করতে চাই। সেটা হচ্ছে যে thank you very much for giving me the floor. First of all, I want to give a modest correction to Kabiruzzaman, although he has given very nice presentation. I enjoyed thoroughly. That is the criteria he mentioned as Jones criteria. Actually, this is a Duke's criteria. This is the modified Duke's criteria having 4 major component and 8 minor component. And very important thing is, which we usually miss, the recent update, the serology, positive serology or PCR for some other microorganism when it is not positive by blood culture. And another is isolation of Staph aureus is another major criteria. This along with the positive blood culture, positive imaging by echo, as well as positive serology, as well as isolation of Staph aureus. And other minor criteria you all know. In 2017, that is 2017,
I will add some points after his speaking. Okay, sir, I have talked to you that it is unlike the Jones criteria. It is the Drew's criteria that is used for diagnosis of the infective endocarditis. But the sum of the feature, the style, that major criteria, minor criteria, like the Jones criteria,
Jones criteria is for
I am not drawing this way. I have talked that there is some similarities between these two criteria. Jones criteria use the major and minor criteria. Deuce criteria use the major.
Sir, I think Sir has correctly mentioned that Duke's criteria is for infective endocarditis.
Dr.
He just tried to draw some similarities.
It looks like the Jones criteria having the major and minor, but it was Deuce criteria. He already mentioned in his slide.
And I have shown
Deuce.
I think
it was a misunderstanding.
Right. I think this is concluded.
No, actually, he has not. I thought that he has not intentionally, unintentional. I think he knows this.
He draw the similarity, not the similarity, only the similarity.
Sir, because I had a presentation on 2017 in National Heart Foundation, because I encountered at least 16 cases of infective endocarditis while I was working in NICVD, particularly healthcare associated infective endocarditis after device closure, after cardiac cath, after valvuloplasty, because the environment where we were working, particularly from cath lab and other usable items we are using. So we are having a lot of complication, and 2 of the patients died in my clinical practice in NICVD. So these are the things, and I want to add. And other thing is, it is very challenging. 10 to 20% of the infective endocarditis is due to healthcare associated and which is preventable by preparation or any intervention. And sir, peculiarly, the organism isolated, we found some unusual organ, which is peculiar for infective endocarditis. We found a case with salmonella infection, and we found a case with IVDA, that is intravenous drug abuser. These are few cases, and most of the cases cultures were negative. And my question to Kabiruzzaman, when culture is negative but the clinical features is suggestive of infective endocarditis, there are three triad, that is one triad, there are three clinical features. Any patient, prolonged fever, not responding to antibiotic, conventional antibiotic, and progressive pallor, and as well as appearance of new murmur, these three are the cardinal feature of clinical feature of infective endocarditis. So in this subset, sometimes we may use indiscriminate use of antibiotics, so we maybe have culture negative. So culture, blood culture negative infective endocarditis is another difficult situation. Most of the mortality and morbidity occurs. So in that case, this serological test as well as the PCR is important. Another comments I want to do regarding the comments of Dr. Khaled Mohsin, the PET scan and scan is also another important thing, particularly in case of the formation of microbiofilm, where there is a prosthetic valve, there is or any foreign materials like device or anything intracardiac foreign body. Usually there is a formation of microbiofilm. So what is this? There are three layers of bacteria. Underlying most inner side there is a dormant bacteria, and in the middle layer there is a proliferating bacteria, and outer layer there is disseminating bacteria. So in such situations, sometimes you may get the culture negative. You may not get the typical oscillating mass of echocardiographic evidence of infective endocarditis. In that case, this SPECT CT scan or PET CT scan is very important for as a diagnostic tool. This is, I want to conclude my comments. Thank you, sir.
Thank you, sir. Thank you, sir, for your comments. I think we should proceed to our second presentation. And the second presentation is on echocardiographic evaluation of tetralogy of Fallot. So this is a very important clinical topic, and this topic will be covered by Dr. Abdullah Shahriar. He is the Associate Professor and Head of the Department of Pediatric Cardiology of NICVD. So let us have his presentation. Dr. Abdullah Shahriar. Dr. Abdullah Shahriar. Shahriar bhai.
Dr. Abdullah Shahriar, are you not connected? Any problem? Where is he?
Shahriar bhai.
Is disconnected or not? Any internal problems?
I am just making a phone call. হ্যাঁ আপনি কই আপনি নতুন করে ঢোকেন আপনার প্রবলেম এটা হ্যাঁ আচ্ছা আচ্ছা আবার করেন তো দেখেন তো হয়ে যাবে
In the meantime, any comments from the any faculty?
Actually, sir, for infective endocarditis, the valve involvement is almost like the rheumatic fever. In rheumatic fever, the mitral valve is the first choice for involvement, then aortic valve, then tricuspid valve. Infective endocarditis is like so. Most prevalent visitation is in the...
It may be explained that the mitral valve is more involved in the rheumatic fever than the other valves.
Yes,
it may
sir.
be explained in that way.
In that way, yes,
because the visitation develop in the damaged valves.
yes, sir.
So more damaged valves is the mitral valve. So the incidence of the infective endocarditis on the mitral valve is more. That may be an explanation.
Yes, sir.
Yeah.
The question to Kabiruzzaman bhai, in percentage of cases, you have to resort to transesophageal echo in a patient who is strongly suspected of infective endocarditis, but no clue is available from a microbiological or transthoracic echocardiographic point of view.
Actually, there is recommendation that if you have the strong suspicion of the infective endocarditis clinically, and you are not getting any clue like vegetation or the thickening of the posterior wall or thickening of the posterior mitral leaflet, annulus, but you have strong suspicion, you have good image, even good, then there is indication then also to repeat the transesophageal echo. Even after doing the transesophageal echo, if you don't get any clue, but you have still the suspicion that there may be infective endocarditis, then you have to repeat the transesophageal echo after 3 to 5 days.
Thank you, sir. Professor Tuhin Haq, madam, are you with us?
Sir,
can I comment?
Yes, madam.
This is Dr. Rizwan.
Yeah, sure.
Sir,
welcome.
Sir, we are getting a lot of new nets with infective endocarditis, mostly vegetations in the tricuspid valve, and these are mostly fungal, huge vegetations. Especially those new nets are in the NICU for a long time, like 1 month, 45 days. These new nets, then they come with huge vegetations at 3 months of age. These kind of units who are in the intensive care unit for a long time and without any invasive line, we are getting this kind of neonates. Neonates, I mean early infants. And also we have one patient with, still the patient is with us. The patient, the child is thriving well. The child is 1 year, 3 months of age, and she presented with high fever and blood culture shows Staph aureus, and the child has pericardial effusion, pleural effusion, and ascites along with large vegetation on the tricuspid valve. And then again, the child developed cardiac tamponade, so we pericardiocentesis done, and that pericardial fluid also shows Staph aureus growth, and that vegetation suddenly embolized and went into lungs. And so this patient with 3 antibiotics, then after 14 days, the fever subsided. So like we are searching that why sometimes we are getting like Staph aureus, like virulent organism causing infective endocarditis in native normal valve without any previous or without any congenital heart disease, even valves are normal.
Dr. Rizwan, has it got any relation with the umbilical venous catheterization?
Some neonates, we search for some invasive lines. No, there is no umbilical line, no central line, even with this neonat. So that's why we encourage the neonatologist when a neonat come get antibiotic for more than 7 days, please start antifungal.
Yes, I am connected down.
Actually, how can you decide that, confirm that that was a fungal?
Candida, blood culture, Candida king, the blood culture. And what we do, we stop antibiotic. If the child is not very toxic, we used to hold antibiotic for 48 hours, and we take 3 blood samples, and then we again start a medical antibiotic. So when we could stop antibiotic for 48 hours and do blood culture, 3 samples, most of the case we get some organism. But if this child is very toxic, we cannot stop
I'm
antibiotics.
talking that you have mentioned that you have get many cases of the fungal visitation.
Yeah,
How can
not
confirm that that visitation was due to fungus? Is there laboratory or history?
Laboratory, yeah. Some patient we get some like blood culture we got candida, and sometimes there is nothing.
Okay.
Low grade fever.
Jonah, I want to add something with you, if I permit it. That is the fungal infection in case of hospital admitted patient. Hospital acquired infection is not uncommon, number one. Because, and number two is the immunocompromised patient may have chance. And number three is it is healthcare associated. The sister nurses who are pushing the IV medication, it may be related with that. Number three, the indwelling catheter or something else. Recently, I found one patient who has RB2PA conduit from India, and after returning Bangladesh, 14 days after, he has severe high fever and all the features of infective endocarditis. And we found vegetation in the pulmonary artery and pulmonary valves. And we cultured several times according to the protocol, but we did not find any bacteria. But ultimately we found candida infection, and we give voriconazole and the patient improved. So this is not uncommon in case of children, but particularly those who are immunocompromised or who are after the surgery, this is not uncommon. So we must think about this fungal infection as a cause of infective endocarditis in case of children.
Thank you, sir. Thank you, sir. By this time, Dr. Abdullah Shahriar Bhai has already connected, and let us proceed to the second presentation of today. Dear audience, our second presentation, as I have already mentioned, that is on echocardiographic evaluation of tetralogy of Fallot, and let us have the presentation. Dr. Abdullah Shahriar Bhai.
Okay.
Are you okay?
Yes.
Please share your screen.
I'm sharing my screen. Okay. No, I'm not sharing my screen. I'm sharing my. Okay.
Have you opened up your presentation?
No, okay. If I find my screen.
Yes. Yes.
I'm not audible.
Yes.
Okay. Thank you very much. Sorry for mechanical interruption. In the meantime, I think some discussions have been done, and I'm not taking time. With the permission of our chairperson, Shafi sir, and our audience, and on behalf of other honorable teachers, my fellows, Assalamu alaikum. I'm Abdullah Shahriar. I'm from NICVD. I'm the Assoc professor in his department. I'm going to present the eco-evaluation of tetralogy of Fallot.
Go to the presentation view, please.
Very common topics.
Go to the presentation view, please. Presentation view, please. Go to the presentation view, please. In the lower panel.
Shahriar, ওই কাপের মতো যেটা আছে, ওয়াইন
কাপের মতো যেটা আছে ওখানে যান।
Press F5.
শাহরিয়ার ভাই, কাপের মতো যেটা আছে। ফুল ভিউতে যান, প্রেজেন্টেশন ভিউ।
এখানে একদম নিচের প্যানেলটায় ওয়াইন কাপের মতো যেটা আছে
যেখানে 73% দেখাচ্ছে আপনার, ওর পাশেরটাই। Right. You have now hit the right point. Yes, thank you.
73%. No,
proceed, please.
No. Okay. Now it's visible. Everything is visible.
Yeah.
Okay?
Yes.
Nicely visible.
I have taken much time. I am more presenting. So it's these are components of tetralogy of Fallot, the basic components, and this on the basis of these components, we are going to go for eco findings, and we want to reveal out the associations TOF and the complications of TOF and the other components. So. So what's the goal of echocardio exam in the Tetralogy fellow? So it is we use these tools. This golden I think it is a very useful tools that is non-invasive. So we can define the VSD size, location, identify the degree of fixed and dynamic alveolar obstruction, and evaluate the general cardiac anatomy and function. Fixed obstruction due to the subvalvular, valvular, and supravalvular stenosis. Dynamic obstruction occurs hypertrophic alveolar.
Shahriar, counter.
Okay, sir. Anything wrong? Hello, sir.
Okay, go on.
I'm audible.
Yes, yes.
A dynamic obstruction occurs as the hepatic infundibulum muscle contracts, causing further alveolar obstruction and over the course of systole. So assessing an accurate pulmonary outflow gradient can be challenging in neonatal life, as that depends on pulmonary vascular resistance, which decreases over the first weeks and months of life. The measure gradient also depends on the presence and size of a patent ductus arteriosus. Therefore, it is helpful to monitor alveolar gradient and presence a patient's systemic oxygen saturation as the PVR decreases and the PDA constricts or closes. ECHO is also used to guide surgical repair with particular attention to VSD size and location, degree of alveolar obstruction, pulmonary valve and pulmonary artery size and stenosis, presence of coronary arteries crossing the alveoli, and diagnosis of other associated lesions that may need to be addressed concurrently. In terms of VSD closure, differentiating between perimembranous outlet versus muscular outlet versus doubly committed VSD can affect how the surgeon performs the repair and the suture lines chosen in order to avoid damage to the cardiac conduction system. So when we have some profiles, whenever we are going to perform an echo, we must complete these profiles. That been, it has been set up by American Academic Cardiology. So whenever we start the echo, we go for VSD morphology, perimembranous outlet, muscular outlet, or doubly committed defect with anterior malalignment of outlet septum, is fibrous remnant in doubly committed, presence of atrioventricular septal defect, any additional muscular VSD. Alveolar obstruction, we also check it out, location and degree of absence of dynamic subvalvular obstruction, pulmonary valve size, morphology, branches, subaortic and aortic morphology, and function sources of pulmonary blood flow, that's PDA and collatus, etc. Arch, sideness, branching coronary artery, anatomy, presence of persistent left superior vena cava, everything we have to detail out. So the basic view, some basic views are there for delineating the TOF. So 5 or 6 views. I'm going to show the basic views, then I'll correlate and the other things and describe the other things. Okay. Let me have some maybe this thing is not opening. Okay, it's a perimembranous types of VSD in TOF, Tetralogy Fallot. The perimembranous outlet VSD located between the limbs of the septal band and extend to the area of fibrous continuity. I think I won't go in details. I go for the I think clips that will be helpful for you all. This kind of VSD 60-70% in case of TOF. This is behind the septal leaflet of the tricuspid valve and below the commissure between the right and non-coronary leaflets of the aortic valve. The muscular outlet VSD 20-30% is have a muscular posterior inferior limb. They are not in fibrous continuity with the AV septum and are located away from the AV conduction pathway and above the system. There is a doubly committed subaortic VSD characterized by complete absence of the outlet septum and results in aortopulmonary fibrous continuity, occurs with hypoplasia of the subpulmonary infundibulum and hypertrophy of the septoparietal band when associated with TOF. So posterior inferior limb is typically muscular, but it can have perimembranous extension. And restrictive VSD It's a typical mechanism impingement of tricuspid valve tissue. So in TOF, it is not always true that there's a non-restrictive VSD. That can be a happening of restrictive VSD due to the impinging of the tricuspid valve tissue, making the constriction. I usually associate with suprasystemic RV pressures. TOF with heavy septal defect is 1.7% of TOF cases, leads to confined inlet and outlet VSD. Look for genetic and extracardiac abnormalities. I think so. Why this happened? Sorry, I'm so. Excuse me, I can go back to my, I think, clip bank, because they are not, I think, in this, yeah, backup. Excuse me, I will go to the clip bank. Is that happening? So can I get attachment again? I'm so sorry. I'm embarrassing you all. Shit.
আব্দুল্লাহ শাহরিয়ার, তোমার এই তো দেখা যাচ্ছে না।
স্যার আমি আবার করছি, লোড করছি স্যার, এটা আমি
তোমার ভিডিও ক্লিপ বোধহয় মুভ করে না, না?
হ্যাঁ স্যার, এটা স্টাক হয়ে গেছে। আমার মনে হচ্ছে আমি আবার করলাম সে ফাঁকে।
কি অবস্থা, এখন শরীর টরীর সব ভালো আছে?
তুমি স্কিপ করে নেক্সটটাতে যাবে নাকি? নেক্সট স্লাইডে চলে যাও আমার।
হ্যাঁ, অজ্ঞান করে লয়ে গেছিল গা। মোবাইল টোবাইল নাই তো, সব লয়ে গেছে। তাহলে এখন ফোনে কত কম কিনছেন? একটা ছোটখাটো নাকি? ছোটখাটো একটা ঘরে আসছিল আমাদের।
সবাই মিউট হয়ে থাকো।
হচ্ছে
প্লিজ
অজ্ঞান করে লয়ে গেছে আমার কাছে।
এভরিওয়ান প্লিজ, এভরিওয়ান মিউটেড। There is some technical problems, I think, Shahriar.
Yes, sir.
You have to skip the video clips, I think.
আমি আমার সাইডে যাচ্ছে স্যার, নাহলে হবে না স্যার। ভিডিও ক্লিপ আসছে স্যার।
Dr. Rajiv?
জি স্যার।
There is a technical problem. Okay, re-entry করবে নাকি আব্দুল্লাহ শাহরিয়ার?
স্যার এটা তো ওনার এখান থেকেই মানে বের হয়ে আবার ঢুকলে ভালো হবে।
ঢুকলে বের হলে কিছু হবে।
মিটিং আছে কথা বলবেন না।
আমার মনে হয় তুমি লিভ করে আবার ঢুকো তো।
জি 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 বের হয়ে লিভ করে আবার ঢুকলে ঠিক আমার মনে হয় প্রবলেম নেই।
কেন স্যার ঢুকার কিছু নাই।
আজিম ভাই ওনার স্যারের ভিডিওর সাথে পাওয়ারপয়েন্ট প্রেজেন্টেশনের সাথে লিংকটা নাই, সোর্সটা পাচ্ছে না, সেজন্য চলতেছে না।
তুমি লিভ করো, লিভ করে আবার এন্ট্রি এই করো, জয়েন করো।
না স্যার, এটা আমার জাস্ট ওই যে পাওয়ার পয়েন্টের সাথে স্যার এটা ওই ভিডিও ক্লিপগুলি পাচ্ছে না স্যার, কানেকশন পাচ্ছে না স্যার। আমি এখন ফাইল একসাথে নিয়ে ফেললাম স্যার, আবার দেখি স্যার।
আবার নতুন করে জয়েন করেন।
শাহরিয়ার ভাই যেখানে মেইন ফোল্ডারটা আছে ওইখান থেকে সরাসরি দেখাতে পারেন।
হ্যাঁ ফোল্ডারে দেখাচ্ছে, আমি উঠে যাচ্ছি, ওটাই করতেছি এখন ফোল্ডারে।
Any comments in the meantime? Any comments from the Naruma or Nilufar Fatima, the pediatricians group present here? Naruma, you have any comments?
Sir, comments. আমি জাস্ট যেটা বলতে চাই, টেট্রালজি অফ ফ্যালটস যে এই জিনিসটা আমাদেরকে, এটা আসলে টোটালি সার্জিক্যাল পার্সপেক্টিভ। সুতরাং এইখানে আমাদের রিপোর্টটা আসলে এই ধরনের হবে যে সার্জনকে যেভাবে হেল্প করা যায়। এক নাম্বার হচ্ছে যে আমরা ডায়াগনোসিস, হাউ টু ডায়াগনোস টেট্রালজি অফ ফ্যালটস। নাম্বার 2 হচ্ছে হাউ টু আইডেন্টিফাই অর ডিসাইড দ্য ম্যানেজমেন্ট প্রোটোকল, লাইক টোটাল কারেকশনে যাবে না প্যালিয়েটিভ শান্টে যাবে, সেটা আমাদের ইকোর বিভিন্ন ডাটার উপর, মেজারমেন্টের উপর ডিপেন্ড করে। আর নাম্বার 3 হচ্ছে পোস্ট অপারেটিভ ফলো আপ। এখানে আসলে আরো যেখানে আমাদের এমডি স্টুডেন্টরা যারা আছে তাদের জন্য খুব ইম্পর্টেন্ট পোস্ট অপারেটিভ ফলো আপ, কারণ এখানে মোস্ট অফ দ্য টাইমে এই পেশেন্টগুলি তাদের কাছেই যায় যারা অ্যাডাল্ট পেশেন্ট টেট্রালজি অফ কারেকশন হয়। যে জিনিসটা আমরা অবভিয়াসলি মিস করি, যেটা ডায়াস্টোলিক ডিসফাংশন, পালমোনারি রিগার্জিটেশন, এবং আরেকটা হচ্ছে যে আমরা ডায়ামিটার গুলি যেটা দেই না, যখন আমরা ফ্রি ফ্লো পিআর পাই তখন আরভিওটি ডায়ামিটারটা আমাদের দেওয়া উচিত, আরভি বেস, আরভি মিড এবং লেন্থ, এটা আমাদের দেওয়া উচিত। আর এভরি টেট্রালজি অফ ফ্যালটস, এবং আমার শুধু টেট্রালজি অফ ফ্যালটস না, অল কেসে আমাদের কিছু ডায়ামিটার দিতে হয়, যেমন মেজারমেন্ট অফ mitral valve, tricuspid valve at the end diastole, and valve annulus, MPA, RP and AP. এটা দিয়ে আসলে আমরা পি এর কতটা মানে পিএটা হাইপোপ্লাস্টিক আর নরমাল রেঞ্জ সেটা দেখে আমরা ডিসাইড করি যে পেশেন্টটি পেডিয়াট্রিক শান্টে যাবে কিনা। এই ডাটাগুলি আমাদের প্রত্যেকটা পেশেন্টের ক্ষেত্রে
হ্যাপি যে আমাকে এখানে ইনক্লুড করা হচ্ছে। যে জিনিসটা হচ্ছে আমি ইন্টারেস্ট পার্সোনালি এর জন্য কার্ডিয়াক সার্জারিতে আগাতে গেলে বা কার্ডিয়াক ডিজিজের শেষের দিকে গেলে মানে
স্যার আমি স্যার একটু যোগ করতে চাই,
দেখি শাহরিয়ার কন্টিনিউ করতে পারে কিনা।
জি স্যার।
আচ্ছা ঠিক
হিসাবে এই অ্যাসোসিয়েশনকে আগে সামনে নেওয়ার জন্য ফাইন্যান্সিয়াল যে দিকটা খেয়াল রাখতে হবে, যেভাবে হোক এনুয়াল সাবস্ক্রিপশন হোক বা
visible? My slide is visible or not? My slide is visible? Everybody? Hello?
No. Not yet.
Your slide is visible.
Is visible? Is it visible? Slide?
Not visible.
Yes, you.
Okay. Now I can start.
Yes, it is visible.
No, not
visible. Continue.
It's not visible yet.
Not visible.
Is it visible?
visible?
I think it's visible. Now it is visible. Hello?
It is visible.
It is visible.
Yes, visible.
And your slide is visible. You can continue, sir.
Okay. So this is the primary view. This is a Suprasternal view showing that
আমরা সবাইকে মিউট করে দিলে ভালো।
aorta. There is the RB septum is hypertrophic, and it is divided. Septum is encephaloid deviation, and there is some bidirectional shunt, predominant right to left shunt. So, and in this view, see that there is aortic and mitral continuity. This is very important because we have to define whether it is that there's overriding is whatever the proportion of the overriding. If there is aortomitral continuity, that is defined as a component of TOF. So here is maintaining is aortomitral continuity. Aorta and mitral continuity is there. And sometimes we measure the distance, it's less than 7 millimeter. When it's less than 2 or 3 millimeter, then the continuity is being disturbed, and there is some pulmonary components being induced here. And so it is it may be defined then at double outer right ventricle. So I have already discussed about the things. Perimembranous VSD is 60 to 70%, and muscular VSD 20 to 30%, and have a muscular posterior inferior limb. They are not in fibrous connectivity with the AV septum and are located away from the AV conduction pathway and above the posterior inferior limb of the septal band. Its double committed VSD is subarterial VSD is also known as, and occurs with hypoplasia of the subpulmonary infundibulum and hypertrophy of the septoparietal band when associated with TOF. Posterior limb is typically muscular, but it can have perimembranous extension. And I think I given this things before, so I won't go further about these things. Now, from that parasternal longitudinal view, it's a modified view. When we move and angle the probe in the left and anterior position, then we can reveal the pulmonary valve, RVOT and main pulmonary artery. And luckily, we are very interesting. There's a PD also there. So this is a modified view from the real plex view, and it should be delineated because without precise coverings, precise measurement of the pulmonary valve, whether it is dysplastic, whether it is the annulus is very much narrow, everything should be detailed. Because whatever the Naruma already told that whatever we see, whatever we depict from a echo picture, it should be it should be given to the comprehensive manner to the surgeons so that they can operate without any clumsy cover-up. So there is a narrow RVOT is there also, band of tissue is there. Now, personal short axis view, this is evaluating RVOT, pulmonary valve, and main pulmonary artery. This is we rotate the probe more clockwise, and in this way we just give the pulse width Doppler, continuous Doppler, then pulse width Doppler, so to obtain the pulmonary and right RVOT gradients, if any there are obstructions there. In the here there is some the pulmonary valve is thickened, and there is RVOT is not narrow enough. So in the end of the when we go giving the Doppler is 64 millimeter mercury as the Bernoulli equation. So it is not severe enough. This is the dagger shaped real there are too many pictures. One is fixed shadow, and this is dynamic shadow. The fixed shadow is for valvular stenosis, and the dynamic shadow is for the infundibular cover-up. So when we go for pulmonary stenosis, we usually we have some gradient, measure some gradient way, the mild, moderate, severe. So any gradient to the RVOT or pulmonary valve is 36 millimeter mercury below is mild pulmonary stenosis. When it is 36 to 64, it is moderate, and when it is severe, 64 millimeter mercury. And the Doppler velocity is along below 3 to 4, above 4. So then when we depict the pictures of pulmonary, then we go for RVOT screening. For RVOT screening, details should be given to the surgeons or the operator who will going to operate the patients. So any subvalvular PS, prominence, septoparietal muscle bands, or trabeculotions that tend to undergo progressive hypertrophy postnatally, pulmonary valve dysplasia, thickened immobile leaflets, commercial fusions, bicuspid in 75% that should be also noted. Possible tethering of leaflets to the pulmonary arterial wall, that should be also noticed carefully. Hypoplastic pulmonary valve annulus, that should be measured, and there is no fixed cover-up. We have some now we have some apps, or we put it in the as per body surface area. Then we give the Z square. Any Z square below -2 gradient, it seems to be not sufficient for the optimum measurement of the structure. Supravalvular PS and branch pulmonary artery stenosis also you should look it out. Hypoplasia or discrete stenosis within the main pulmonary trunk and branch pulmonary, that should be also measured. That should be look out. Possible ductal shelf in the left pulmonary artery, that we should reveal out carefully. Now it's apical fourth chamber view. In apical fourth chamber view, we usually it's not a primary finding for the TOF. When we go for apical fourth chamber view, then we slowly fixed our probe in clockwise position to reveal the RVOT tract. And this is also to give you the impression whether the RV is of equal volume of LV, RV is hypertrophied or not. It is in this picture, this clip is RV is near about the size of LV, so mildly hypertrophied. Now for fourth chamber, now we go for apical five chamber view. This view will give you another impression like the overriding of the aorta. In this clips, it's subaortic large subaortic VSD, and and he also modified the views and giving that impressions of pulmonary stenosis and subvalvular stenosis that is depicted. Again, I'm repeating the clip from the apical 5-chamber view. We're rotating the probe in the more posteriorly and in the clockwise position. And this is the gradient of the pulmonary valve and in the lower tissue. And the gradient would continuous giving there is a dagger shape or and is dynamic shadow over the impression. So apical 5-chamber view will give you the spectral Doppler across the right ventricular outflow tract and pulmonary valve from the apical 5-chamber view anteriorly. Dagger-like Doppler pattern consistent with the dynamic obstructions that I told before, and second super Doppler pattern consists with the fixed obstruction across the pulmonary valve. Now the subcostal long axis view we are depicting is to delineate the LVOT, and through that LVOT we also we are revealing the overriding of the aorta with large VSD, large melanine VSD, and then we will go for subcostal short axis to go for the RVOT track. This is the mimicking the same plane of the angiogram lateral view of the RV lateral view to go for the whole RVOT tract and also pulmonary valve, and also if there is any double chamber right ventricle, any obstruction in the right ventricle. And in this view we have seen that there is no that much gradients along the subvalvular level or RVOT level. Pure the gradient in the valvular level. Again, I mean. Now the suprasternal view is a useful view majority of the time, when we missed out this view, but it's a very useful view because along with TOF, I've also given that associations. There's some arch abnormality. There's some PDA coarctations. Everything is there. So without suprasternal view, we can't depict all these things. And arch should be measured systematically, because if the patient having any hyperplasia, if the patient needs any kind of shunt operations, then this arch should be delineated, and also the arch, as long as the vena cava is being showed, that should be revealed through the suprasternal view, because we have to when we have to go for shunt, we have so systemic and venous shunt should be operated. That's why we should delineate all the great arteries, including subclavians, innominate arteries, that's innominate arteries, and the ipsilateral pulmonary artery. Everything should be delineated. So subcostal abdominal. Before that, whenever you will get PDA, sometimes in case of tetralogy of Fallot, PDA can be delineated because there is some severe valvular stenosis. There may be a coarctations. So that to depict the PDA, the real PDA, we'll go for the subcostal abdominal cover up. So in subcostal abdominal cover up, the spectral Doppler interrogation of the abdominal aorta below the level of the diaphragm, revealing hollow diastolic flow reversal in a patient with a large PDA, represented by this arrow. These are things. So secondary to diastolic runoff into a PDA in diastole. So it is another indirect evidence that there is a PDA, large PDA. So what are the variants of TOF? So we know the TOF is the plain variant is pulmonary stenosis, subvalvular, valvular, supravalvular. But other than valvular stenosis, TOF may associate with pulmonary atresia, TOF with absent pulmonary valve syndrome, and TOF with atrial septal defect. Sometimes we tell it Tetralogy, but now it is not told. It's that just mentioned as TOF with atrial septal defect. So the important thing is TOF with pulmonary atresia. These are the odds. TOF is whenever TOF with this is which is fine 4 components, no other complications like atresia, pulmonary valve syndrome. This is a much convenient case for a surgeon to take over. But when there is association of pulmonary atresia, pulmonary valve syndrome, then the other things come up. Whether there is a 2-stage operations and whether we think about RV functions, everything should be in consideration. And now, apical 4-chamber view, we are going to depict and it would go for pulmonary valve and tricuspid valve. This view is useful whenever there is some RV dysfunction, a long-standing case of sometime in our country, the patients who used to cover to us, they came in the fag end, and it's very difficult for us to give some good hope, good aspiration to the patient so that they can go for a smooth surgery. So that's why we should have some cover up, whether RV is dilated, hypertrophied, and there's enough TR gradient should be revealed out. And also in this view, while we are depicting the RVOT, pulmonary valve stenosis is being depicted in this view, 4-chamber, apical 4-chamber view. Say. And now the TOF with the first view that I'm giving you that time. They're now I'm now repeating these things. Now it is different from the real parasternal long axis view, and we have just we're just putting the probe more anteriorly and clockwise, so that whole of the pulmonary valve can be delineated. This is a, in fact, you have seen that this is a picture having the valve is freely moving. This is a evidence of absent pulmonary valve. Is there? No, there is no valvular structures. There are fixed structures there. Now I'm going to talk with a short axis view, pulmonary artery. Go for these pulmonary valve structures and also RVOT. And in this view, there is valve is the valve element is not dysplastic.
শাহরিয়ারের বোধহয় ইন্টারনেটের খুব সমস্যা। হ্যাঁ শাহরিয়ার শুনতে পাও নাকি? না, ওখানে ইন্টারনেটে খুব সমস্যা হচ্ছে শাহরিয়ারের। The problem is that he took the video clips from by taking from the screen by the camera. That is why the quality is not that good. not from the directly from the machines, I think. Any comments from the faculty present here? Dr. Kabiruzzaman, can you, or Khalid Mohsin, do you like to have some comments?
Actually, I want to comment regarding the TOF.
Yeah.
It is my very favorite subject. I am not practicing it. Actually, it's an echocardiographic evaluation of the tetralogy of Fallot. So, I think first fundamental things is to understand the deviation of the conal septum. That is the main pathology for understanding of the tetralogy of Fallot. There is deviation of the conal or infundibular septum, leftward, anteriorly, and cavalry. And this can be very good, nicely appreciated by parasternal short axis view. One should keep in mind that the LBOT is a circular structure. That is outlet septum from the pulmonary artery. It takes a curved semicircular course and comes to join with the membranous part attached to the septal lip of the tricuspid. If you imagine that short axis view at the great vessel level, that is the normal anatomy. But in case of TOF, in the conal septum deviated leftward, that is towards the pulmonary valve, towards the RBOT free valve, and this makes the RBOT stenotic. And in addition to this, there are some muscular brands and hypertrophy. That is the main pathology for tetralogy of Fallot. If anybody wants to, in one sense, that decide the is it tetralogy of Fallot, then he needs to very carefully study the parasternal short axis view at the great vessel level or the out.
Thank you, sir.
Another thing confusing is that sometimes in the parasternal low axis view, the trabecular septum, there is severe pulmonary hypertension. The RB compress the interventricular septum towards the LB. That makes an false impression of the malalignment. So in that case, one should go for the short axis. And I think these two views are very useful for learners and for experts. I am very comfortable with this view. Other things, now I have said the many parameters of need for repair of the surgery.
Abdullah Shahriar, are you ready to continue?
Yes, sir. Can I have a comment?
Yeah, please.
Sir,
I think they let Abdullah Shahriar to continue to complete his presentation.
Sir.
Abdullah Shahriar.
Sir, কিছুদিন আগে আমি PhD লেকচারে আমি ডায়াগ্রামেটিক্যালি এই সেপ্টাল ডেভিয়েশনে কিছু ছবি দেখেছি। তো দেখলে মনে হয় উপকৃত হবে।
আজকে যদি থাকে তুমি ইউ ক্যান শো ইট এট দি এন্ড অফ দি প্রেজেন্টেশন। তোমার সাথে আছে ওগুলি? ক্যান ইউ শো দেম? জামা?
জি স্যার।
হ্যাঁ, যদি থাকে তাহলে এই প্রেজেন্টেশনের পরে ডিসকাশনের সময় দেখো। কন্টিনিউ করো।
স্যার এটা হচ্ছে না আমার আবার।
আচ্ছা স্যার, আমি একটু ইন দ্য মিন টাইম একটা বলি যে ওই যে আপনারা এক্সামিনার যারা তারা পরীক্ষার সময় একটা জিনিস জানতে চান যে ইকোকার্ডিওগ্রাফিক্যালি টেট্রালজি অফ ফ্যালো এবং ডাবল আউটলেট রাইট ভেন্ট্রিকল কিভাবে ডিফারেন্সিয়েট করা যায়, এটা Dr. Kabiruzzaman has nicely described it. And another thing, during echo examination of the TOF patient, we are sometimes doing the suprasternal view to exclude the associated coarctation of aorta or the aortic arch anomaly. But we have to be very careful when we are doing the suprasternal view, because the pressure on the suprasternal region can induce a cyanotic spell in some of the patients. And we have to have the resuscitative equipments ready at hand in the echo room as well. I don't know, I have some experience of, though I presently do very little echo, but I hope the echocardiographers, high volume echocardiographers can throw some light on this problem while we are doing the suprasternal view.
I want to add a point regarding this, regarding the suprasternal event. Yes, there is suprasternal notch and fossa. If you press firmly, there may be a problem. But my technique is that I used to fill up the fossa with jelly.
With jelly?
With jelly. Then I lightly apply the probe. That is the best way.
So you are not pressing very hard actually on
No, I am not pressing. It's a very discomfortable to see the suprasternal, and it is the last part of echo exam. Because for child, it's a very phobic position, and they start screaming.
Another thing, the surgeons, they sometimes want to know a formula, but I don't know how relevant it is clinically. What is called the Magoons Formula before they embark on a total correction of TOF. So how do you supply this information to the cardiac surgeons?
Nakata and Magoon ratio is taken from the diameter of the right pulmonary artery, left pulmonary artery, the radius of the right and left pulmonary artery dividing by the descending thoracic aorta measurement at the level of the diaphragm. And what is the significance of this Nakata and Magoon index? If Nakata is more than 200,
can you repeat, please, Naharuma? What the thing, the ratio? Can you repeat the ratio again?
Sir, that I have told that we have to give some measurement. One thing is mitral valve annulus and tricuspid valve annulus at the end diastole. We have to take this measurement and we have to do the ratio of tricuspid and mitral valve. If it is more than 0.65, that means LV is adequate, so surgeon can go biventricular repair. That means total correction is closure, RVOT resection. And another important thing is measurement of the pulmonary artery. That is taken at the level of the RPA, LPA radius. We take the diameter of the LPA and RPA and divide by the descending thoracic aorta. This should be taken from the CT or cardiac cath. But ECHO guided us that if we take the RPA, LPA is plastic.
Sir, can you see the slide? Sir?
Yeah, please. You go to the part from where you stopped before.
Right. Now it's visible, sir?
It is visible.
So,
but you take the video clips by the camera, I think, from the machine.
Okay, sir. Yes, sir.
But you have to take the video clips from the directly from the machine.
Last slide was there. It's a ASD with TOF for chamber view. And this should be done by subcostal view. I just for the comprehension, so that it's along with TOF. That's why I giving this view. It's not an ideal view. The ideal view, you must have some subcostal view. IBC and SBC rim should be delineated so that we can have some TOF. In TOF, we may miss the small ASD or PFO because there is some right to left shunt that can be missed. So should be and this PFO or any PDA, these are the lifelines. So that should be dealing out carefully. Now this view revealing the absent pulmonary valve. Beauty, pulmonary valve is there. It's a free PR jet is going through the pulmonary valve. This is a pulmonary long axis view, parasternal long axis view, and comparing the color and the and there's a free PR. The free PR is there. So when there is free PR along with stenosis, that will there's some comprehension of that. There's a absent pulmonary valve, and these patients rather than having spell, the patient may have some RV failure because of the free pair. So this should, the patient management is being changed. Along the absent pulmonary valve, in case of Tetralogy Fallot, it is not that it's not like all the time we'll go for beta blockers all the time. When there is some absent pulmonary valve, the patient may need some diuretics also to combat heart failure. This Suprasternal view typically showing the double chamber right ventricle. This is another interesting points of Tetralogy Fallot. The RV is being divided in proximal and distal half, some band of tissues, and this should be revealed by the echocardiographer, because if we not give these things if we not represent all these things to the surgeons, they may leave behind all these things, and there is some enough gradient along the RVOT, and this will again be problematic for the child. So again, I'm showing the so this is the proximal chamber, and this is the proximal chamber, the pulmonary valve, the subvalvular stenosis is producing, and this is the distal chamber. Oh my goodness.
So
and in the meantime, I'm just continuing the discussions of Naruma, because I'm now going to cover up for pulmonary artery. He is talking about the Nakata index and Magoon ratio. So Nakata index, now the index now points now have been modified recently. Previously the Nakata index was is a sum of the body pulmonary area of the left and right pulmonary artery area divided by surface area. So it is millimeter square, pulmonary artery square divided by millimeter square. This is the unit value. So it was 200. Now the modified value is had been taken as 150. And in case of Magoon ratio, the index is 1.6. It is just the Narum already described it. The Magoon ratio is the total of pulmonary, just at the entry point of the bronchus of the main left and right pulmonary artery, divided by the abdominal aorta at the level of diaphragm. So, but this thing is whenever there is a hyperplastic PA, this Magoon ratio is more reliable when we go for cardiac cath in the angiographic view, when we go to get the values, and this has been comparatively that has been seen that the Magoon ratio when it's a hyperplastic PA, or we are in our sense when put the data in the apps, we have some apps that seems to be that pulmonary is not that much confluent enough, then we should go for some cardiac cath, because the pulmonary, it is the essential figures along with the tricuspid valve annulus, along with the arch view, along with that RVOT. The pulmonary is the prime figures that should be given. We should, I think, we should clear out all the views, all the measurements very clearly to the surgeons. Without this, because any hyperplastic PA, that is not convenient for a complete correction of the Tetralogy Fallot.
Thank you, Dr. Abdullah Shahriar. I think even due to some technical interference, we do you have anything to show again? But there is a lot of technical interferences from your side. Let us have some discussion rather on the topic.
Okay, sir. And
sir,
I think
যদি আমাকে পারমিশন দেন, আমি ওইটা একটু দেখাইতে চাই আর কি। আমি আবার একটা অন্য কাজে যাব।
Now
Sorry.
we are also at the end. We have also completed more than 2 hours. It is 12:18. কে করতেছো স্ক্রিন শেয়ার?
Deviation of the
Kabiruzzaman করতেছো?
Okay. Yes, sir. I want to share it.
Okay.
Okay.
Ji sir, আমি একটু করতে চাই.
Okay. Please. Kabiruzzaman.
Okay, sir. I'm just continue. Sorry.
During this period, just one question came here: how to differentiate a pink TOF from a cyanotic TOF? Just echocardiographically. One thing in pink TOF, there is dynamic obstruction, so there will be good flow through pulmonary arteries. So the size of the pulmonary artery will be good in normal size. And
actually, আমি তো শেয়ার করতে পারতেছি না.
Another thing is infundibulum is well developed, so there is not so much of infundibular hypertrophy. These two things will guide us that it is a pink TOF, or clinically we will get that patient has a cyanosis or above 90%, more than 85%, and patient is no cyanotic spill.
Thank you. Kabiruzzaman.
Sir, আমার স্ক্রিন কি দেখা যাচ্ছে?
Yeah.
Sir, actually, the malalignment that can happen in 2 different levels. One is between the conal septum and trabecular septum, and another is the interictus septum and inner part of the interventricular septum. And the malalignment may be between the conal septum and trabecular septum. It is characterized by deviation of the outlet septum in relation to the adjoining trabecular parts. And this type of malalignment have main 3 parts. One, the anterior malalignment that is found in the TOF. Another is the posterior malalignment that is found in the interarticular aortic arch. Another is the rotational malalignment that is found in the thoracic beam malformation of the DORB. And this is the schematic I have told you. So if you see, this is the short axis schematic. This is my own hand drawing. This is the at this position. This is the septal leaflet of the tricuspid valve, and this is the pulmonary valve here. So this is the conal septum. This should naturally come to this course and unite with this, the insertion of the septal leaflet of the tricuspid valve. But instead of coming to this direction, it goes towards to this direction. What is this direction? This is the anterior direction, and this is the left direction. So, in case of TOF, whenever there is anterior and leftward deviation of the conal septum in short axis view, that is the deviation of the conal septum in TOF. And if you think of the parasternal long axis view, this is the conal septum, and this is the trabecular septum, and this is the deviation. Another slide. And you can see this is the TOF. This is the real picture of TOF patients. This is the parasternal. It is deviated to this direction. That is the main pathology of tetralogy of Fallot. And it is compromising the orifice of the lumen of the RBOT, and there is some hypertrophy. This is the one example. Another same. This is the real picture of the TOF. This is the conal septal deviation, and this is the video loop. You can see this is the conal septum. This is the pulmonary. This is the septal leaflet of the tricuspid valve. This is the aorta, and it is deviated instead of. And that this is the another example, parasternal long axis view to show the deviation. So these are walls that I have. This another picture. This is not easy to understand. So most of the person, those who really daily practice the subcostal views, they can understand it. Actually, this is a subcostal view. This is the sagittal view. So this is the anterior direction. This is the posterior. This is the cranial part. This is the caudal part. And we can see This is the trabecular part of the intermacular septum. And this is the conal septum. And this septum should come to this direction. Instead of coming this direction, it is gone to this. This is the anterior, and this is the towards the head or cranial deviation. So in TOF, there are deviation in 3 directions. One is leftward, another is anterior, and third one is the cranial. So thank you, sir. These are some slides of.
Thank you. Thank you, Kabiruzzaman.
Sir.
Any comments? Khalid Mohsin was trying to make some comments, sir. Unmute, Khalid Mohsin. You have to unmute yourself.
Okay, sir. Actually, it's very clear from the deliberation of Professor Dr. Kabiruzzaman, because it's quite a frequently asked question in the examination, the differentiation of tetralogy of Fallot from the double outlet right ventricle and TOF and acquired. Other thing is in a long-standing VSD, there is some adaptive changes in the heart. So it is also, it needs to be differentiated from tetralogy of Fallot. I would like to have a comment from our pediatric cardiologist, Dr. Nahruma or Professor Salam, or so how to differentiate this congenital TOF from acquired TOF.
Dr. Nahruma, do you like to comment?
Sir, acquired TOF is what happens, sir, that Kabiruzzaman sir has shown that conal septum. We found that when we are following this group of patient, we we got the patient at 3 months. We get that conal septum is hypertrophied, but there is no deviation, and there is no obstruction. There is dynamic flow acceleration seen at the RBOT level. But when we are following this group of patient, when the time goes on and progresses on, this conal septum is deviating leftward and anterior and cephalad. When it is fulfilling this criteria, then we refer this, we label this as tetralogy of Fallot, because there is deviation this conal septum. If there is no deviation, then we label it as VSD with RBOT obstruction. So when there is deviation, then we label it as acquired TOF.
Okay, any comments from Abdullah Shahriar? Do you like to add? Abdullah Shahriar? Professor Salam, do you like to add? No? It is okay? Professor Abdul Salam?
Yes, sir.
Anything to add?
একটা জিনিস সিম্পলিফাই করতে চাই, কারণ কোনাল সেপ্টাম সম্পর্কে অনেকেরই আইডিয়া নাই, বিশেষ করে আপনারা যারা ইয়েতে আছেন পেডিয়াট্রিক কার্ডিওলজির এটা ভালো বুঝে অ্যাডাল্টের কবিরুজ্জামানও চেষ্টা করেছে। কিন্তু আপনার প্রশ্নের যেটা ছিল যে পিঙ্ক টপ ইজ অ্যাকচুয়ালি clinical scenario, and it depends upon the degree of RBOT obstruction. আমরা সিম্পলি যদি চিন্তা করি, there is a RBOT and there is a LBOT. RBOT তে আপনার proximal portion, distal portion. RBOT mainly conal septal tissue বা muscular tissue দিয়ে তৈরি। এখন এই যে এখানে যদি লেভেল অফ অবস্ট্রাকশন প্রক্সিমাল থাকতে পারে, ডিস্টাল থাকতে পারে, অথবা হোল সেগমেন্ট থাকতে পারে। যদি মাঝখানে থাকে তখন একটা ডাবল চেম্বারের মতো একটা থার্ড চেম্বার। এরপর আপনার ভালভ শুরু হলো, এরপর আপনার মেইন পালমোনারি। এখন যে আমাদের ওয়ার্কিং ক্লাসিফিকেশন, যে আমরা কখন হাইপোপ্লাস্টিক বলবো, কখন ফেয়ার সাইজ বলবো, কখন আমরা গুড সাইজ পিএ বলবো, বিকজ স্যার tetralogy of Fallot is a surgical disease. Actually there is no medical management except for a few days, except propranolol. So surgeon wants to know something important, that is the RBOT obstruction levelটা কোন জায়গায়। সেটা আপনার মিক্সড হতে পারে, সেটা আইসোলেটেড হতে পারে, পালমোনারি ভালভ হতে পারে, সাবভালভুলার, সুপ্রাভালভুলার যেটা বলছে, ইভেন ডিস্ট্যান্টও হতে পারে। এখন নোমেনক্লেচার নিয়ে আমরা যে জিনিসগুলো নিয়ে আসতেছি, TOF এর other variants, actually this has been absolute. There are two schools of thought. One is by Van Perak from America and another is from Europe by Anderson. এদের ভিতরে এই নোমেনক্লেচার নিয়ে গত 70 বছর যাবত এই ডিবেট হচ্ছে স্যার। পিকুলিয়ার হচ্ছে যে ওল্ড যে নোমেনক্লেচারগুলো সেগুলো কেউ ড্রপ করছে না। নিউয়ার ক্লাসিফিকেশনে সিম্পল TOF and complex TOF বলা হয় অনেক সময়। Complex TOF, these are the separate entities. Separate TOF with pulmonary atresia. Pulmonary atresia many মানে classification, variation অনেক কিছু এবং ট্রিটমেন্টও আলাদা। সো আমরা TOF চিন্তা করি তাহলে আমরা প্রথমেই চিন্তা করব আরবিওটি অবস্ট্রাকশন আছে না পালমোনারি ভালভের অবস্ট্রাকশন আছে না ডিস্টাল পালমোনারি অথবা মিক্সড আছে। এটা হচ্ছে বেসিক থিং। আর ওয়ার্কিং ক্লাসিফিকেশন আদার দেন দি ইন্ডেক্স, ওই নাকাতা, ম্যাকগুন এবং জেড স্কোর রিসেন্টলি বলা হচ্ছে এবং অ্যাপস আছে, আমরা মোবাইলে অ্যাপস রাখি। মেইন পালমোনারি প্রথমে আমি ওয়েট এবং হাইট দিব, চলে বিএস চলে আসবে। এরপরে আমি মেইন পালমোনারি কত সাইজ আর পিএ কত সাইজ দিলে আমার জেড স্কোরটা চলে আসলো। ইফ ইট ইজ লেস দেন 2.5 জেড স্কোয়ার ভ্যালু তাহলে এটা আমরা হাইপোপ্লাস্টিক বলি। তো এখন ওই ক্যালকুলেশনে না গিয়ে আমরা ওয়ার্কিং যেটা করি স্যার সেটা হচ্ছে যে আমরা জানি যে আমরা আর্টেরিয়াল ট্রাঙ্কটা একটা ছিল আগে, হ্যাঁ, এমব্রিওলজিক্যালি এটাকে স্পাইরাল সেপ্টাম দিয়ে দুই ভাগ করছে। স্পাইরাল সেপ্টামের লোয়ার পার্টটাই হচ্ছে কোনা সেপ্টাল টিস্যু, যেটা ডেভিয়েশন হয়ে পালমোনারি আর্টারি বা ইনফান্টিবুলামকে ছোট করে দিচ্ছে ইন কেস অফ টপ। সো ওয়ার্কিং ইয়ে হচ্ছে যে আপনি অ্যাওর্টিক ডায়ামিটার নেন at the annulus of the aortic valve, plus আপনি pulmonary annulus নেন at the annulus of the pulmonary valve, যোগ করেন। যোগ করলে সে ফর এটা যদি 15 হয় আর ওটা যদি আপনার 5 হয় বা 7 হয় তাহলে টোটাল যা হলো তাকে আপনি 2 দিয়ে ভাগ করেন। কেন? আমার pulmonary artery এবং aorta should be equal in size. ওকে, এখন pulmonary annulus আমি যা পেলাম, আমার branch pulmonary artery at least 60% of the annulus of the pulmonary artery হইতে হবে। এখন টোটাল যে আমি পেলাম, মনে করেন যে আমি 21 পেলাম কম্বিনেশনে, তাহলে অথবা 20 পেলাম, তাহলে আমার পালমোনারি আর্টারি সাইজ 10 হইতে হবে। এখন 10 এর যদি আমি 3 ভাগ করি, 3 ভাগ করলে যদি এটা আমার মানে মোর দেন 2/3 ইট ইজ গুড সাইজ, হ্যাঁ, লেস দেন 1/3 টু লেস দেন 2/3 টু মোর দেন 1/3 ইট ইজ হাইপোপ্লাস্টিক ফেয়ার সাইজ। আর যদি লেস দেন 1/3 হয় তাহলে এটা হাইপোপ্লাস্টিক। যদি হাইপোপ্লাস্টিক হয় তখন চিন্তা করতে হবে আমার যদি পিন টপ থাকে হাইপোপ্লাস্টিক পালমোনারি আর্টারি, সো আই হ্যাভ টু থিঙ্ক ফর দি ম্যাপকা অথবা পিডিএ, কোনো একটা কোলেটারাল সার্কুলেশন আছে। কারণ টেট্রালজি অফ ফ্যালট বেসিক্যালি ইজ এ ডিক্রিজ পালমোনারি ব্লাড ফ্লো গ্রুপ অফ সায়ানোটিক হার্ট ডিজিজ। সুতরাং এই ডিক্রিজ থাকলো না, পালমোনারি অ্যানাটমি খারাপ, অথচ দেখা যাচ্ছে তার স্যাচুরেশন ভালো, হ্যাঁ, তার স্পেলও হয় না। সো দিস আর দ্য টপ। এগুলো আর ইউজুয়ালি হয় কি ডিফারেন্ট আসে এবং লার্জ দিয়ে থাকে স্যার। These are my few comments, sir. Thank you.
And that is a good statement, Professor Abdul Salam, for the persons like us, that আমরা যারা adult cardiologists, we like to understand the things, but we usually do not refer the patient to the surgeons. You refer the patient to the surgeon, but we have to understand. When your simple formula is more understandable to us than that others complex formulas. Thank you. Dr. Kabiruzzaman, any comments? Dr. Kabiruzzaman? Dr. Kabiruzzaman, are you with us? No. Professor Shahriar Kabir, do you like to make some comments? Shahriar Kabir? Shahriar Kabir? Do you listen to me? Any comments? Any comments?
No, sir. I have learned a lot from both the speakers. Thank you, sir.
Asad?
Thank you, sir.
Asad?
Thank you, sir. Actually, I have a question to our first speaker, Professor Kabiruzzaman, sir. Day before yesterday, I saw a patient in my echo lab. I found that a young lady, echocardiographic finding was there is a gross dilatations of the root of the aorta with severe aortic regurgitations. But I found that at the posterior wall of the aortic wall, there is a thrombus or vegetations. As you stated that the vegetations located at the downstream side, so how can we explain the vegetations attached with the posterior root of the aorta? This is the first question. And second question is, in case of vegetations, if it is in the downstream side, is it applicable or is it same for the thrombus formation?
I think Dr. Kabiruzzaman is not with us because he was telling that he has had some work. And any answer from anyone?
The vegetation is still, sir, mentioned in upstream side. In aortic valve, flow of upstream, not downstream.
It is in the regurgitation. In the case of the regurgitation, it is on the ventricular side.
Ventricular side, and for the
But
mitral
in the aortic
regurgitation in the
stenosis, it is on the aortic side.
aortic side.
Yeah.
According to definition, microbial infection in the endovascular surface anywhere, but যেটা বলা হচ্ছে upstream-এ এটা আসলে commonly seen, but uncommonly you can see anywhere.
When the jet impinges, sometimes where the jet impinges, that will also the site of the focus of the infective endocarditis. Dr. Anisul Awal, do you like to?
আমি স্যার একটু যেটা অবজার্ভ করলাম যে যেসব কনজেনিটাল হার্ট ডিজিজ বা যেসব স্যার ভালভুলার হার্ট ডিজিজ সার্জনস রিকোয়ারমেন্টস লাগে, যেমন আমরা বলছি সার্জনরা এটা চায়, তো যদি স্যার এটা পসিবল হয় নেক্সট টাইম সার্জনরা যদি থাকে, ওনারা যদি ওনাদের এক্সপেরিয়েন্স বলে যে আমরা যে রিপোর্ট গুলো দিচ্ছি এটা কি হেল্পফুল হচ্ছে নাকি এটা ওনারা রিয়েল প্রবলেম ফেস করছে, তাহলে আমরা হয়তো স্যার ওনাদের পয়েন্ট অফ ভিউটা আর একটু ভালো শুনতে পারতাম। আরেকটা স্যার যেটা আজকে টেকনিক্যাল প্রবলেম হলো, এটা যদি স্যার এমন করা যায় যে আমরা যে বিভিন্ন জায়গায় সিজি প্রেজেন্ট করি, আগের দিন আমরা ড্রাই রান বলে ওরা, আমরা একবার চালিয়ে দেখি, যে যাদের প্রোগ্রাম অর্গানাইজার ওখানে চালিয়ে দেখি, এটা যদি পসিবল হয়, যদি ডক্টর রাজীব এবং ওনারা যদি যারা প্রেজেন্টার আছে একবার সিজিটা যদি আগে দেখে নেয়, মানে প্রেজেন্টেশনটা যেটা রান করছে কিনা, তাহলে হয়তো স্যার এই ধরনের সমস্যাগুলো কম হবে স্যার। আর আমার একটা ছোট্ট কোয়েশ্চেন আছে স্যার, লাস্ট কোয়েশ্চেন, সেটা হচ্ছে আমরা স্যার মাঝে মধ্যে আমাদের মেডিকেল কলেজে আমাদের যেহেতু এখানে পেডিয়াট্রিক কার্ডিওলজিস্ট নাই, আমাদের নিউনেটদের করতে হয় বা স্মল চাইল্ডদের করতে হয়, ওদের আমরা একটা স্যার পেয়েছি রাইট সাইডে ভেজিটেশন পালমোনারি ভালভ অ্যারাউন্ডে, অ্যান্টিবায়োটিক পেয়েছে লং টাইম, পেশেন্টটা ফলো আপে আসে, কিন্তু পেশেন্ট ক্লিনিক্যালি ভালো, কিন্তু ভেজিটেশন পারসিস্টিং, খুব একটা সাইজ বেশি চেঞ্জ হয় নাই, এটা দীর্ঘদিন রয়ে যাচ্ছে, তাহলে এটা স্যার ভেজিটেশন কতদিন থাকতে পারে বা এটা থেকে গেলে এটার কোনো ইমপ্লিকেশন আছে কিনা, এই ব্যাপারে স্যার আমি একটু জানতে চাই স্যার।
স্যার এটা নিয়ে আমি একটু বলতে চাই স্যার, কারণ আমাদের এখানে সার্জারি হয় এবং আমরা আপনি যেটা বললেন এই ধরনের কেস ফ্রিকোয়েন্টলি পার অপারেটিভ আমরা পাই। অবভিয়াস যেটা ইকোতেও পাই না, কিন্তু পার অপারেটিভ সার্জন আমাদেরকে বলে যে পালমোনারি ভালভের ওখানে বা আরবিওটিতে অনেক হিল্ড ভেজিটেশন ছিল, কারণ টেট্রালজি অফ ফেলোটসে বিশেষ করে যেখানে আরবিওটি অবস্ট্রাকশন থাকে, যখন ন্যারো জেট দিয়ে ব্লাড যায় তখন ব্লাড স্ট্রিমে ওখানে এন্ডোকার্ডাইটিস হয়ে ভেজিটেশন হয়, হয়তো বা পেশেন্ট অনেক সময় সেটাকে খেয়ালও করে না, বা যখন যাচ্ছে লোকালি তখন লোকাল ওরাল অ্যান্টিবায়োটিক দিয়ে ট্রিট হয় এবং ট্রিট হয়ে ওই ভেজিটেশনটা হিল্ড হয়ে থেকে যায়, যার জন্য যখন আমাদের কাছে রেফারাল পাচ্ছি আমরা হয়তো বা ওইখানে হিল্ড ভেজিটেশন পাচ্ছি, বা অনেক সময় ছোট ছোট মাইক্রো ভেজিটেশন যেটা হয়তো বা চোখেও পড়ছে না, যেটা পার অপারেটিভ সার্জন এসে আমাদেরকে বলে যে এই পেশেন্টের ভেজিটেশন ছিল, এটা আমরা ফ্রিকোয়েন্টলি পাই। সেই জন্য এটা হিল্ড ভেজিটেশন আমরা ওই ভেজিটেশনের সার্জি ক্রাইটেরিয়া গুলো অসিলেশন, ডেনসিটি, ওই জিনিসগুলি খেয়াল করে এবং ক্লিনিক্যাল ফিচারের উপর এবং বায়োকেমিক্যালি অ্যাক্টিভ কিনা সেই জিনিসটার উপরে এভিডেন্স বেস আমরা ওইভাবে দিতে পারি।
Okay, thank you. Any comments for any other? Dr. Ajoy? Do you suggest CMR for this patient, top patient?
না স্যার, আমি অ্যাকচুয়ালি CMR না, আমি অ্যাকচুয়ালি স্যার ওই যে মাল্টিমোডালিটি ইমেজিং ইন ইনফেক্টিভ এন্ডোকার্ডাইটিস আমি এটাতে বেশি ইন্টারেস্টেড। আমাদের অনেক সময় স্যার সেন্সিটিভিটি স্পেসিফিসিটি দেখি, ইকো as outstanding sensitivity specificity, but sometimes we fail to recognize the pyrexia of unknown origin. In that case, we can take help from CT, especially abscess and pseudoaneurysm in that in this. And another thing, Professor Abdul Salam has nicely mentioned the role of PET-CT. Role of PET-CT in device-related or prosthetic valve-related complication like infective endocarditis. In that case, PET-CT has outstanding result. This lights up. Only the infective area lights up, taking the like neutrophil bacterius takes the FDG PET and it lights up. In that case, we many of times we can miss by echo, and in this scenario, we can help from PET-CT. In MRI, as MRI has very limited temporal resolution, and MRI image is the summation of a different phase. So regarding detection of vegetation, MRI has low sensitivity. This is the infective endocarditis perspective. Another one is a TOF regarding multimodality imaging. In TOF, there is increasing role of MRI, especially post-operative TOF complication, especially RV volume and function. It has immense role to detect the accurate volume and function for the decision taking whether pulmonary valve replacement required or not. I think MRI in that case very nice role.
Thank you. Thank you. Any comments? We are at the end. Dr. Pinaki Ranjan, do you like to say anything? Dr. Abu Jaid Basunia from Rangpur. I see the names on my screen. Dr. Nishit Kumar is also. Dr. Kabiruzzaman, no comments. Any comments from you, Nishit?
Sir, thanks, sir. Nice discussion. Nowadays, infective endocarditis is sometimes, sir, Sir, am I? Am I audible, sir?
Yeah.
Sir, infective endocarditis is sometimes neglected. I have seen some cases, they are getting admitted and inadequately treated and are discharged. So this should be given importance. And that's my point of view, sir. Thank you, sir.
It is, surely, it is a deadly disease. You have to diagnose early, you have to evaluate it, you have to properly treat, but you have to diagnose, you have to suspect the cases very early, even from the peripheral areas where there is a little support of the echocardiography or others, but then you have to suspect that this patient will be maybe suffering from the infective endocarditis, and so you have to refer the patient for further evaluation to the center where it is possible. That is a good idea. Yeah. Dr. Abu Basunia, do you like to make some comments? Or Pinaki Ranjan? Dr. Pinaki Ranjan? I think no comments from them. Then we can conclude. I think it is a time of 12:40. No other comments from any faculty. Then we can conclude. Thank you very much for participating in this session. আমাদের আসলে আগেও আমি বলছি যে এই সমস্ত সেশনে not that we learn or we learn the things, rather we learn the points which should we learn. কি পয়েন্টস আমাদের করা উচিত। যেমন আমি একটা জিনিস আমি অ্যাডমিট করি, প্রফেসর আব্দুল সালাম একটা আমি আপনার যত কথাই বলছেন, আমার লাস্ট একটা কথা বলছে যে when you see the pink color, if you see there is a severe stenosis of the RBOT, then think of he has got the MEPCA or the PDA, because pulmonary circulation is going on, but there is so it is a pink. And other thing, Naruma was explaining that it may be not that much, it is a dynamic obstruction and there is a good flow. এই যে এই কিছু tips bits learn করা, that's a very important things of these sessions, যে আমরা টিপ বিটস গুলি আমরা শিখতে পারি। এবং আমার মনে হয় যে আমি এই যে আজকে this is the 18th session, আমি তো প্রত্যেক 18 সেশনে ফুল টাইম আমি থাকছি, যে আমি মানে কি বলা যায় যে ভূতের বেগার খাচ্ছি তা না, কিন্তু আমার মনে হচ্ছে যে আমি অনেক কিছু শিখতে পারছি, যে জানতে পারছি বা অনেক কিছু ক্লিয়ার হচ্ছে ইত্যাদি। এবং আমার মনে হয় সবারই এখানকার যারা ফেলোস, যাদের জীবনযাত্রা শুরু হচ্ছে, তাদের জন্য এটা ভেরি ইম্পর্টেন্ট যে হোয়াট শুড উই লার্ন অ্যান্ড হোয়াট উই ডোন্ট নো, এই জিনিসটাও মাথার মধ্যে ঢোকা, যে আমরা তো এটা খেয়াল করি না, আমরা তো জানি না, এই জিনিসটা আমাদের জানতে হবে। তো আমার ডক্টর মনোয়ার মডারেটর একটু অফ ছিল, তুমি জয়েন করেছো, ডু ইউ লাইক টু মেক সাম কমেন্টস ডক্টর মনোয়ার?
থ্যাংক ইউ স্যার। আসলে আমি একটু অন্য প্রোগ্রামে গেছিলাম, যাই হোক এই বলার অপেক্ষা রাখে না যে এই জিনিসগুলো, যে যত প্রেজেন্টেশন যত কথাই হোক না কেন, কিছু কোর ইনফরমেশন আমাদেরকে যখন দিন মোহাম্মদ স্যার নিউরোলজি পড়াইতেন তখন বলতেন যে রুল অফ থাম, সব ভুলে যাও, আলটিমেটলি এই কি পয়েন্টস গুলো ভুলে যাওয়া যাবে না। যে প্রত্যেকটা প্রেজেন্টেশন এক্সপার্টদের কাছ থেকে শোনার কিন্তু এটাই মানে ইম্পর্টেন্স, যে উনি কিছু সুর ধরাই দিবেন, কিছু ইম্পর্টেন্ট পয়েন্ট ধরাই দিবেন, যেটা কিনা প্র্যাকটিক্যাল লাইফে মোটামুটি ভাবে বিক্রি করে খাওয়া যাবে, দিন চালানো যাবে, পেট চালানো যাবে, এটা আর কি। তো আমরা এরকম টিপস এন্ড বিটস আশা করি প্রত্যেক এক্সপার্টের কাছ থেকে, এই যেটা আজকে বিশেষ করে কবিরুজ্জামান স্যার কিংবা শাহরিয়ার ভাইয়ের কাছ থেকে আমরা যেটা হয়তো বা জানলাম, শুনলাম, দেখলাম, ভবিষ্যতেও জানবো, শুনবো। স্যার বিশেষ করে এই জিনিসটাতে খুব ইম্পর্টেন্স দেন। আশা করি আমাদের ভবিষ্যতের প্রোগ্রামগুলোতেও আমরা এই দিকগুলো খেয়াল করব এবং চেষ্টা করব আমরা এগুলোকে হাইলাইট করব। তো এটাই আমার আশাবাদ আর কি। আজকে আসলে 17তম দিন শেষ হলো, সামনে হয়তো আমরা আরো বর্ণাঢ্য বিভিন্ন রকমের প্রেজেন্টেশন এবং আয়োজন নিয়ে উপস্থিত হব।
আমরা আসবো আগামী 16 তারিখে। আর মনোয়ার, আমাদের প্রেজেন্টার থেকে আমরা শিখলাম ডক্টর কবিরুজ্জামান এবং ডাক্তার আব্দুল্লাহ শাহরিয়ার। আব্দুল্লাহ শাহরিয়ার একটু টেকনিক্যাল ইন্টারফারেন্সের জন্য কিছুটা বিঘ্নিত হয়েছে, যদিও তবুও সে অনেক ক্লিপ নিয়ে আসছিল। কাজে আমরা উই লার্ন ফ্রম এ লট ফ্রম দেয়ার প্রেজেন্টেশন। কিন্তু এর সাথে সাথে আমাদের এখানে যারা ফ্যাকাল্টি থাকে তাদের যে কন্ট্রিবিউশন, এটাও কিন্তু মানে কি বলা যায়, অনেক সময় সারপাস দি কন্ট্রিবিউশন বাই দি প্রেজেন্টেশন। এটাও আমাদের একটা বিরাট পাওয়া, এবং উই আর ভেরি গ্রেটফুল টু দি ফ্যাকাল্টি যে যারা জয়েন করে আমাদের বিভিন্ন জায়গা থেকে, সেই রংপুর থেকে, সেই রাজশাহী থেকে, চিটাগাং থেকে যারা জয়েন করছে, তারা কিন্তু একটা স্টিমুলাস, সিলেট থেকে তারা, একটা দিনাজপুর থেকে তারা একটা স্টিমুলাস ফর আওয়ার দিস এন্ডেভার। আমার মনে হয় যে আর ফ্যাকাল্টি তৈরি করাও কিন্তু আমাদের একটা উদ্দেশ্য। এখানে যারা প্রেজেন্টেশন করতেছে আজকে যতটুকু ভালো হলো না, আগামী প্রেজেন্টেশন আরো ভালো হবে, আমরা কিন্তু ডিসার্টেন হওয়া উচিত না। আমাদের উচিত যে যারা আমাদের টিচার্স, যারা টিচার্স হিসেবে আছে, তাদের উচিত যে বিভিন্ন প্রেজেন্টেশন নিয়ে আগে আসে। আমি কিন্তু সবাইকে ইনভাইট করি যে তাদের নিজেদের ছোট করে প্রেজেন্ট করেন, তারপরে কি বলা যায় কেস প্রেজেন্টেশন করেন। এইভাবে কিন্তু ইউ হ্যাভ টু মেক ইউরসেলফ এ গুড ফ্যাকাল্টি অলসো। খালি শুনলেও হবে না। শাহরিয়ার কবিরকে দৃষ্টি আকর্ষণ করতেছি, আসাদের দৃষ্টি আকর্ষণ, আসাদ অবশ্য অনেক করে, ইন্টারভেনশনে করে, এদের সবারই দৃষ্টি আকর্ষণ করি যে অজয়কেও করতেছি যে তোমরা তোমাদের প্রেজেন্টেশন গুলি করো এবং ইউ গিভ মি দি সাজেশন যে কি ধরনের প্রেজেন্টেশন ভবিষ্যতে আরো হতে পারে। তাহলে আমরা 16 তারিখে আমরা কি পয়েন্টস নিয়ে আসবো এখনো আমরা ঠিক করি নাই, কিন্তু আমরা দেখি হয়তোবা ট্রান্সএসোফেজিয়াল ইকোর বেসিক্স, তারপর স্ট্রেস ইকোর বেসিস, এগুলি কতগুলি জিনিস আমাদের রয়ে গেছে, কন্ট্রাস্ট ইকোর বেসিক্স রয়ে গেছে, স্ট্রেইনের উপরে আমাদের এখনো আলোচনা হয় নাই, প্লাস বিশেষ করে কিছু কেস বেস স্টাডিজ নিয়ে আমরা হয়তো আলোচনা করতে পারি। এগুলি নিয়ে আমরা আগামী সেশনগুলিকে আমরা তৈরি করব। আমরা চাই যে জিনিসও ভালো হোক, আবার ফ্যাকাল্টিও তৈরি হোক, দুইটা জিনিসকে আমরা করতে চাই, মিলাতে চাই আমরা। এবং আমরা এই জন্য বাইরের এই লেকচারার, কিন্তু আমি আরো অনেক বাইরের লেকচারারকে আমি ইনভাইট করতে পারতাম, কিন্তু আমি কিন্তু খুব সিলেক্টিভলি কিছু বাইরের স্পিকারদের ইনভাইট করেছি এই জন্য যে আমি চাই যে আমাদের ন্যাশনাল স্পিকারসরা হাইলাইটেড হোক, তারা ট্রেন্ড আপ হোক, তারা আরো ভালো করুক, as good as any other speakers হোক, এবং এটা সম্ভব। I assert it is possible. Our national speakers can present their presentation as equally as good as any other international standard. এটা সম্ভব যদি আমাদের কমিটমেন্ট থাকে এবং ইচ্ছা থাকে। তো বিফোর এন্ড I also thank Beximco Pharmaceutical as usual, যে তারা কন্টিনিউয়াসলি এন্ড কনসিস্টেন্টলি আমাদেরকে সাপোর্টটা দিয়ে যাচ্ছে, পার্টিকুলারলি ডক্টর জামশেদুল হাসান রাজীব, who is always with our program, ডিজাইন করা এবং তা সার্কুলেট করা, সেটা করে যাচ্ছে। আবারও সবাইকে ধন্যবাদ দিয়ে আবার 16 তারিখে আবার দেখা হবে এই প্রত্যাশা ব্যক্ত করে আর সবার থেকে বিদায় নিচ্ছি। খোদা হাফেজ। খোদা হাফেজ।
স্যার, একটু অফ দ্য